Good morning. I'm Charles Shapiro. I'm the President of World Affairs Council of Atlanta. And Helene Gale is the President and CEO of CARE, headquartered here in Atlanta. My job is to get things rolling, to get everybody quiet and get things moving. I want to welcome you all here. It's a pleasure. The World Affairs Council, if you don't know what it is, there's a table outside with a bunch of people who will explain it to you and take your money if you'd like to join, and I urge you to do so. A couple of housekeeping items. Number one is put your phones on vibrate. Actually, I guess I should do that too. Do you have it prepared? Because I can wait. I got it. Okay. They told me I got 10 minutes. I'm going to use 10 minutes. Number two is, but keep your phones out and do tweet about the day, and the hashtag is supposed to be on here somewhere, but I don't see. Oh, there it is, Global Health ATL. So please tweet, because we would love that. There's going to be question periods throughout the day, and I've got to ask you to keep the questions short. 2 sentences, not your dissertation, and the question should end in a question mark. The agenda has changed a little bit, and so there are actually printed agendas on the tables, if I'm not mistaken, or you can find it at our website. But now I want to just ask you a question. How many of you are health care professionals? And I'll let you define that yourself. Please raise your hands. That's terrific. How many of you have know Latin America and the Caribbean personally? That's huge. I'm delighted to have you here. I'm going to, just a couple of facts for people who really don't know Latin America and the Caribbean well. Number one is, it's a long name, and so we're just right here. We're going to state for the record that every time somebody says Latin America, they mean Latin America and the Caribbean, okay? But this is no insult to the Caribbean, okay, Jacob? Number two is that there are 30, if you exclude the United States, and I'm not sure you should, because I think we're part of Latin America and the Caribbean, but there are 34 countries in Latin America and the Caribbean. Hugely diverse countries. They range from one of the poorest in the world, Haiti, with a GDP per capita of $820, to leading emerging economies like Colombia, Brazil, Mexico, Chile. Chile's got a GDP per capita of almost $16,000. Latin America and the Caribbean is huge geographically. Brazil is the size of the United States without Alaska. Chile, if you were to superimpose it on the map of the United States and put one end of Chile at Key West, the other end of Chile goes past the north end of Hudson's Bay. That's how long it is, and it's only, that wide. It's also, Latin America is not where you think it is. Almost all of South America, except for a teeny little bit of Peru, is east of Atlanta. East of Atlanta. I used to live in San Diego until a few months ago. It is a shorter flight from Atlanta to Mexico City than it is from San Diego to Mexico City. There are 600 million people in Latin America. The combined GDP is $5.6 trillion. It's mostly considered to be middle-income countries, except for a few countries in the Caribbean and Central America, and that means that there are not assistance programs for health from the European Union, from the United States or Canada, from the Japanese, from the traditional aid donors. And having said that, there are huge disparities within Latin America. Now, we're not talking about a remote region of the world, at least for us. There's over 45 flights a day to Atlanta Hartsfield International Airport from Latin America and the Caribbean, bringing over 5 million passengers a year. 11% of the metro area is from Latin America and the Caribbean, with 500,000 in the 4 counties, the 4 core counties of the metro area. Strong economic growth over the past decade and a half combined with conditional cash transfer programs and resource transfers to the poorest people, has meant a quick improvement in overall health indicators. And the amount of GDP devoted to healthcare has doubled from 3% to 6% during that same time. So that, I guess the good news is that non-communicable diseases is the largest cause of death in Latin America and the Caribbean, although I don't know that any cause of death is good news. But there's something else, too, that we need to keep in mind and that we're going to talk about after lunch today, and that is the homicide rate. So that you've got a number of the countries in the world with the highest homicide rate are in Latin America and the Caribbean. Just to give you an idea, the homicide rate in the United States is 5 per 100,000 people. In Chile, it's only 3 per 100,000 people. In Haiti, it's 10. In Mexico, it's 22 per 100,000. In Trinidad and Tobago, it's 28. Colombia, 31. In El Salvador and Guatemala, it's 40. In Honduras, it's 90 per 100,000. And then if you take specific cities, in Caracas, the homicide rate is 134 deaths per 100,000 people. And in San Pedro Sula, the most violent city in the world, it's 187 per 100,000 people. That's compared to 5 in the United States. So you have this enormous range of issues, of healthcare issues defined if you include violence and violent death as part of that, this huge range of issues that we're going to talk about today. I want to thank Steve Morrison from CSIS, who's helped arrange this, Helene Gale from CARE. I also want to thank our sponsors today. We've got Coca-Cola, UPS, and the Robinson College of Business, which are the major sponsors of this event. And I also want to thank Hartsfield-Jackson Airport and the CDC Foundation. So thank you very much. I appreciate it. Helene, I'm going to turn the microphone to you. Thank you very much.
Thank you very much, Charles. And I'm going to try to be very, very brief. Mine was really just to add a welcome to all of you. As I look out in the audience, I see several people who are veterans of these conferences. This is now the 4th time that the World Affairs Council, CARE, and CSIS have put this convening together. And it's always been different than what we expect from the very beginning, and how it evolved is always a little bit organic, and we know that this will be the same for this meeting. I think the range of issues that Charles so aptly pointed out shows us that that this area that we talk about as if it is one area is an incredibly diverse area with incredibly diverse issues. And so I think today, just like all the other global health convenings that we've done, I think it's going to be incredibly exciting. I also did want to just add, along with our sponsors, how much we want to thank the other partner organizations. And they're listed on the back of your brochure. I'm not going to go through all of them, but I think one of the things that has been so wonderful about this convening is the partnerships that have developed, and particularly here in the Atlanta community, where we have so many organizations devoted to global health and global development. This is an opportunity for people to come together and really think about networking as well as the substance of the conference. I just also wanted to give a brief plug and intro. All of the intros of the people who will be speaking are in depth in your bio, but Charles didn't have a chance to introduce himself. We are very proud to have him as the president of the World Affairs Council of Atlanta since the end of 2000, I think it's September 2014. He comes with a wealth of background as a foreign service officer, including ambassador to Venezuela, years of experience in this region. So we in Atlanta are very, very happy to now have him as the president of the World Affairs Council. So enjoy the day. We hope that this is a program that has something for everyone, and that the audience will have the opportunity to participate, ask questions, and really make this an interactive session throughout. So again, my welcome from on behalf of CARE and the other partners of this convening, and let's have a great day.
Good morning. I'm Steve Morrison from CSIS. I'm the Senior Vice President there and direct the global health work. Delighted to be here again for the 4th year of the Atlanta Summit. Special thanks and note of gratitude to Helene Gale, who's completing her 9th year of leading CARE and has been so integral to this and many other partnerships. Helene, thank you for being trustee for many years with CSIS, close friend, and an intellectual leader par excellence. I mean, someone that everyone looks up to in many different ways, and it's just been such a huge pleasure. And I want to also thank everyone from the World Affairs Council: Cedric Sussman, Claire Morton, Mish Spank, Hannah Koski, Jason Smith. I haven't named everyone, and I apologize for those that I've forgotten, but the World Affairs Council has really made this a major event and shown great capacity as we've evolved it over the years. Senator Isaacson has been quite integral from the beginning for these summits. We're very grateful to him. His leadership has stemmed from his commitment to Georgia, his commitment to CDC, his engagement in foreign affairs in the Senate Foreign Relations Committee in various leadership positions. His special interest and passion on Africa and on development, and in this case, extending his remarks to Latin America and the Caribbean and what they mean from the standpoint of the U.S. and from the standpoint of Georgia. This year, because of the need to convene yesterday and into this week on the reauthorization of the Patriot Act, this was unforeseen scheduling change. He's unable to be here with us today this morning and sends his regrets, but he has pre-recorded a statement, a brief statement by video to help open things up here today, to kick things off. So we're going to turn to that video, and then we'll move to the first part of the program, which is to hear from Dr. Thomas Frieden, who will present from here in a moment. I'll introduce Tom. So if we could tee up the video
Hello,
from
I'm
Senator
United States Senator Johnny Isaacson from the great state of Georgia. I'm delighted to welcome you to the 4th Annual Health Summit, World Health Summit, sponsored by the Center for Strategic and International Studies and the World Affairs Council of Georgia. This is a great event, and it's been an honor for me to be at each and every one of them the last 4 years. Unfortunately, I have to be in Washington today at the last minute, so I could not be here in person, but I'm glad to provide this greeting to you and welcome you to this summit today. I want to thank all the participants in the Council for Strategic and International Studies and the World Affairs Council for all they've done to make it possible. You know, there is no bigger issue than health. I serve on the Health Committee in the United States Senate, and I serve on the Foreign Relations Committee in the United States Senate. Health is the biggest threat that all of us have if we don't contain it. Look what we learned from the Ebola outbreak in Africa. When an outbreak of a rare disease like that takes place, the world takes notice, and we realize what could happen to us if we're not prepared for the worst of circumstances. It's appropriate this summit's in Atlanta, Georgia, because Atlanta is the center for much of the health care of the world. Dr. Tom Frieden will speak in a few minutes. Tom Frieden is the director of the Center for Disease Control in Atlanta, the world's health care center. Without CDC and their effort, the Ebola outbreak, which took place and was contained, might still be running rampant today. And look at Emory University, one of the 4 containment areas in the United States, which was able to take an Ebola patient, take care of them, nurse them back to health, and bring them back safely to the United States of America. Atlanta is a great center and a great city, and the state of Georgia has a great investment in providing health care. We're focusing on Latin America and the Caribbean in this particular segment, and I think it's important that we do so. There are a lot of lessons to be learned from Latin America. You know, it was 1876 when 1,000 Georgians living in Savannah and Chatham County died from yellow fever. Because Brazil, Cuban, and American doctors came together, studied the outbreak, and finally determined it was carried out by mosquitoes, the first stopping of yellow fever actually took place in the United States because of the Caribbean Initiative, the Brazilian Initiative, and the American Initiative. Later on, the Pan-American Health Organization was formed in 1902 and later became a part of the World Health Organization. And just look back 25 years ago. 25 years ago, the number one cause of death in Latin America was diarrhea. Today, diarrhea is number 20, heart disease is number 1. Why? Because we focused on the problems of bad water and sanitation and improved the lifestyle of people in Latin America and the lifestyle of people in the Caribbean. This is all about learning, growing, and helping the people of America and the people of the world have a safer, healthier environment. We all know that economics is one of the common denominators to disease. The more poverty there is, the more disease there is. So as we improve the life of people and the plight of people, we'll improve their health care as well. And America has demonstrated over and over again an ability to be a great partner around the world to solve some of health care's greatest problems. PEPFAR, the initiative by President Bush and President Obama to see to it that we begin to eradicate AIDS on the continent of Africa. AIDS has now plateaued and is declining in most countries because of the retrovirals the United States is providing and because of the training we provided through CDC and others to the healthcare agencies of Africa. There are many, many other examples around the world, like malaria, where the reductions in malaria because of bed nets has taken place. Civic organizations and universities alike have contributed to these programs to see to it that malaria is not the threat it used to be. While it still exists, it's more and more manageable today. Health is something you cannot do without, and you obviously cannot live without, and it's important that the World Affairs Council has sponsored this symposium today. I welcome you and thank you for coming. I wish you the very best, and I commend the Center for Strategic and International Studies, the World Health Council, the World Security Council, and all the others that have been part of it for making it a great day. God bless each and every one of you for your attendance, and God bless the United States of America.
Tom, would you like to come on up and we'll get started? Last night, a number of us came together for a dinner, and Dr. Luis Alberto Moreno, the president of the Inter-American Development Bank, was our keynote. Tom, please have a seat. And we started that discussion over dinner around one of the big issues that's here to hear from Dr. Tom Frieden, which is how do health security issues and questions around building the capacities to prevent, detect, and respond to outbreaks, how do those issues figure in the Caribbean and in Latin America? And a couple of very powerful points, Tom, came up in the course of that dinner that I think deserve mention right now. One is from President Moreno, when he reflected on how the Ebola outbreak was received in the region, in the hemisphere. He said that fears were very high, that there was a sense of vulnerability, especially among the least equipped countries, Haiti and others in the Caribbean. People remembered the devastating impact of $9 billion impact of H1N1 in 2009. There was a fear that if Ebola had been imported into one of the more vulnerable and heavily densely populated countries, that there would have been severe migration impacts out of that. We also heard from Dr. Arturo Suracan, who's with us, Ambassador Arturo Suracan, who's here today, and we'll hear from him. His reflections around what this meant as seen from Mexico in 2009, in which he marveled at how Mexico City, the entire population of 18 million people, could be mobilized in response to the threat in 2009. And he tied that success back to the partnerships, the very strong, outstanding partnerships that had been created between the Mexican government, municipal authorities, and the U.S. Centers for Disease Control and Prevention. So those were both very powerful reflections that came up unprompted last night in the course of the discussion, where we said, over the course of this day, health security was going to be one of the 4 top line issues here. Now, we're here right now to hear from Dr. Thomas Frieden. He's been director of CDC since 2009. This is a period of remarkable continuity of leadership. And as we've all come to know very well, this is a person who's quite exceptional in bringing forward a boundless energy and a strong vision of U.S. leadership and engagement in public health across a broad spectrum of the challenges that means both at home and abroad. And he's brought a special passion around the global health security agenda. When President Obama launched in February of 2014 the Global Health Security Alliance, and that has carried forward with initially 27 countries and World Health Organization, a number of other international bodies. That marked a turning point, and it was something that had been moved ahead on the force of Tom's vision and activism on that. As Ebola hit, and that crisis began to really build in its momentum in the summer of 2014 and into the fall, into what became a runaway crisis that luckily has been brought under control since then. Not completely, but certainly the worst of that crisis is over. Tom Frieden was at the forefront, and I think we can look back that CDC itself as an institution. This was a watershed moment. Over 1,200 CDC employees served and rotated into positions in West Africa as part of that response. As Congress came forward on a bipartisan basis to approve the $5.4 billion in emergency funding, it was remarkable that $1.8 billion of that emergency Ebola money went to CDC. $600 million for capacity here in the United States, $600 million to finish the job in West Africa, and $600 million to create new capacities in West Africa. That's unprecedented. It's an unprecedented thing, and it's evidence of the confidence and the trust that CDC has come to acquire in this period under Tom's leadership. So Tom, thank you so much for being here today and for coming to share your thoughts on this question around how health security figures in the Caribbean and Latin America. Thank you so much.
Thanks, Steve. It's great to be here with you. And thanks so much to the World Affairs Council, to CSIS, and to CARE USA for bringing us together. I think I've been at all of these for the past 4 years, and it's a great chance to have a discussion, think about what more can be done, and explore some of the areas where we've made some progress, but can make even more. It's interesting to think about the context of Latin America and the Caribbean, because the region has been at the forefront of a lot of health advances, polio eradication. I remember when people thought it was impossible, and then this hemisphere did it, and it became a global push. Elimination of measles, done first in this hemisphere. And I'm hopeful that some of the new health threats that we're facing, heart attacks, strokes, cancers, we'll see some real breakaway progress in this region. But let's talk for a minute about global health security, because we have a real paradox today. The paradox is that we're better prepared than ever. We have more technology, we have more healthcare facilities, we have the ability to do things that we could never do before in health and public health, and at the same time, we are more vulnerable than ever before. We're more vulnerable not just because it's an increasingly interconnected world where, whether it's food poisoning or water or air or travel, we know that disease is just a plane ride away, but also because of 3 real threats. The first is of emerging infectious diseases, whether that's Ebola in West Africa or chikungunya in the Caribbean or dengue. We know that we see, on average, 1 new organism per year somewhere in the world, new to the world, and that regularly we're seeing organisms enter areas that they hadn't been endemic in before and pose real threats to health. So the first trend is of emerging infectious diseases. The second trend is of the increase in drug-resistant organisms. Antibiotics are scarce resources. In fact, tomorrow at the White House, there will be a forum that will bring together public and private sectors to address what may be one of the most serious health threats facing us. I'm an infectious disease physician by training. I've cared for patients who've had organisms that are resistant to all antibiotics. Unfortunately, that situation is becoming more and more common. We talk about a pre-antibiotic era and an antibiotic era. If we're not more careful than we're being today, we'll be in a post-antibiotic era. In fact, we already are in a post-antibiotic era for some organisms and for some patients. And organisms can spread rapidly from one part to another. In fact, since we don't always talk about all of the Americas, I'll say that one of the particularly resistant forms of drug resistance that we are seeing in the US came down from Canada. Very unusual that we see that. Usually we share our problems in a different direction, but we see that really the world is all connected. And the third risk is the risk of intentionally created organisms, something that someone works on in a laboratory and either because of malicious intent or mistake gets out. Unfortunately, the same things that are great technologies that make it easier to respond to threats, to detect threats, also make it easier to make deadly bacteria. Excuse me. Now, faced with those three threats, we have a tremendous opportunity because the world recognizes that there's a lot that we need to do together, because there are examples of success. For example, China, if you contrast the response to SARS, which cost the world more than $40 billion, and H7N9, it was really night to day. From the moment H7N9 was recognized in China, they were completely open about it. They posted onto the internet the sequence of the organism. That sequence allowed us here in Atlanta to make a diagnostic test for H7N9, which we distributed around the country and around the world, and to begin work on a vaccine. But that is not something that is available everywhere in the world. We don't yet have the core things that we need, which are fundamentally the early warning systems, detection systems. That means laboratories, epidemiologists, surveillance systems, information systems. We don't have the response capacity through emergency operations centers and trained epidemiologists. And we don't have the capacity to prevent wherever possible through vaccination, safe food, safe water. Ebola was and is a tremendous challenge to the world, and it fundamentally tells us two things. First, we are only as strong as the weakest link, and West Africa was a very weak link when it came to public health. And second, when a country's capacities are overwhelmed, we need to be able to surge in with a global response that's robust, resilient, and effective. Both of those things are essential. There's no shortcut here. You can't say, well, we're going to have a good global system, so we don't really need to build up country capacity. Country capacity is always going to be there first, fastest, most efficiently, and most effectively. But there will be times when country capacities are overwhelmed, so you have to have that global ability to surge. There's a lot to be proud of in Latin America and the Caribbean. There's a lot of progress, but there are also special vulnerabilities. There are parts of the Caribbean, Haiti in particular, that resembles parts of Africa. In fact, in our work rebuilding in West Africa, the experience we have that's most similar to that is our experience in Haiti. We also recognize the risk of natural disasters, that we've seen earthquakes, floods, storms, and we know that infectious diseases can come from anywhere. No one expected that the first pandemic of the 20th century would come from Mexico, and yet it did with H1N1. There's also the challenge that people can think that infectious diseases and global health security aren't really that important, because until something bad happens, it may not be apparent how important those systems are. So ensuring that there's a focus on the political commitment to invest in public health and continue those investments even when things aren't in the headlines is very, very important. Haiti provides a really important example. With the earthquake and the cholera epidemic following the earthquake, Haiti faced a really catastrophic situation based on a country that was already by far the poorest and sickest in the hemisphere. And though you don't often hear the words Haiti and progress in the same sentence, in fact, over the past few years, working with the Haitian government, working with non-governmental organizations, working very closely with the Pan American Health Organization and others, there has been real progress in Haiti. Today, compared to before the earthquake, there are about twice as many people on effective treatment for HIV. Treatment of tuberculosis has improved. The vaccination rates are nearly twice as high. New vaccines have been introduced that are saving literally tens of thousands of lives per year. And all of this has been done in a way that has built Haitian institutions and capacity. Haiti is well on the way to eliminating filariasis, a disfiguring disease. And recently, we're seeing very encouraging possibility of the elimination of malaria from the island of Hispaniola. It's been eliminated from the other islands in the Caribbean. It can be eliminated from Haiti. I didn't believe that a year ago, but my staff has convinced me, based on rigorous data, that it is possible to make tremendous progress and even eliminate malaria from the Caribbean by eliminating it from Haiti and the small areas in the Dominican Republic where it's also present. There's been tremendous progress with malaria prevention and control, but much more is needed. And part of that is going to happen by targeting services where they're needed most. And that's one of the most important lessons for public health and for global health security, the issue of targeting, getting buy-in, investing time, money, effort. The CDC Foundation has received a grant of nearly $30 million from the Bill and Melinda Gates Foundation to fund a collaborative initiative, the Haiti Malaria Elimination Consortium. And the goal of that is to create a malaria-free zone in the entire Caribbean by 2020. That's very ambitious, but we think it's achievable. It's evidence-based. Now, it isn't only the infectious diseases, it isn't only the unexpected diseases that are important as we build public health capacity. Influenza remains a major challenge and a major impact on productivity in this country and around the world. We've worked with the Pan American Health Organization and Barbados and a few other countries to work on a program on hypertension control. High blood pressure has fittingly been called the neglected killer, the silent killer. High blood pressure affects about 2/3 of all people above the age of 65, about 1/3 of all adults. It's the only thing in the world that kills more people than tobacco. And yet it's preventable through improvements in nutrition, and it's treatable through low-cost, effective, once-a-day medications. And yet it's generally not being done well. Hypertension treatment is the exception rather than the rule in most of Latin America and the Caribbean. And yet, if you're going to improve one thing in healthcare that would save the most lives, it would be hypertension. So there are lots of important issues to address in Latin America and the Caribbean. Ebola is a reminder that the next thing we face is probably not going to be the thing we're preparing for. And that's why what's so important is that we prepare the system to identify unusual events, to respond effectively, to figure out how to prevent, and then to prevent effectively. So I really thank you for this opportunity to be with you this morning, and look forward to the conversation.
Thank you. Thank you, Tom. We have about 15 minutes. Maybe I could pose a few questions, but I think we have an opportunity to get a few others from the audience. So Tom, first of all, can you talk a bit about the Global Health Security Agenda and what that means? And where does Latin America and Caribbean fit in that? It may not be immediately obvious, but it is meant to be something that has a global reach. It is something that's meant to bring about a common set of goals, a streamlined sense of the 12 objectives, references of the countries beginning to evaluate one another, to stir a different type of collaboration and mentality globally. Can you say a few words about that?
The Global Health Security Agenda is fundamentally about creating a safer world, a world where devastating epidemics are less and less likely to occur. That is done through three core things: better detection, better response, and better prevention. For each of these three things, the Global Health Security Agenda has detailed, measurable, what we like to call failable metrics. It's not about health for all. It's about a very specific, measurable agenda that will result in core capacities that are consistent with the international health regulations of the World Health Organization and will allow countries to address health threats that are of greatest import to them. I think of dividing the world into three parts. There are the OECD countries, which need to make sure that their own houses are in order and that they help the low-income countries. There are low-income countries that need to commit resources and prioritize this area, but need assistance, technical and financial. And there are the middle-income countries, which at a minimum should keep their own houses in order, and we hope and are increasingly seeing them work in a South-South collaboration with other countries to strengthen those core capacities of prevention, detection, and response. I'll call out Peru because they volunteered to be one of the first countries to undergo an independent objective assessment of their level of preparedness. One of the challenges with the international health regulations is that it is a self-assessment. And the global health security work envisages an independent, objective, transparent, public assessment of preparedness. And if that's present, we think that will result in an incentive for countries to do better and a pathway or guide for donors and OECD countries which want to help countries to figure out where they need to provide the most assistance.
Can you say a bit about, last night when we were talking with President Moreno, the Inter-American Development Bank is 20% of its resources. A dramatic amount of money goes into health. And he talked about investing in readiness, and he mentioned specifically about dengue and chikungunya. And he talked about the sense of vulnerability. So I took that as a pretty strong signal that the partner countries themselves, who are the key members, who are the core members, that these sovereign states themselves have embraced this concept of readiness that aligns very closely with this, that yes, Peru's stepped forward and become active in the self-referencing and the self-assessments, but it's much bigger than that too. Can you say a bit more, like what would you anticipate looking out over the next few years? These threats are episodic. They come and they go. They're difficult to predict. Your efforts are to get people to lock into a sustained, significant commitment to build these capacities. That's partly what we heard from President Moreno last night, was that this is already something that has risen to be a priority in the lending practices that reflect these sovereign states. What are you seeing?
There's been so much interest and attention in health care. The issue of public health is generally not as well understood, and there's not as much attention to it. But the public health capacity is crucial, and that means laboratory networks. That means competent laboratories. It means epidemiologists or disease detectives who can investigate outbreaks. And optimally, that's done through a national public health institution, something like Fiocruz in Brazil. Very, very strong organization in Brazil that has functions that actually are overlapping with CDC, but in some ways broader than US CDC. We're working with the Caribbean and with Guatemala to try to establish national or regional public health institutes there. Fundamentally, if you want to upgrade the capacity of a country to improve their health status, you need to have data to drive it on. And that data is going to come from public health surveillance systems, it's going to come from laboratory networks, it's going to come from intensive analysis that is done not ignoring the healthcare system, but on a different plane than the healthcare system, thinking of public health more broadly. Now, interestingly, Latin America has a history of publicly funded healthcare that may allow it to more easily expand the public health efforts. And there are many parts of Latin America that have very strong public health systems to further build on or share regional capacities.
Thank you. Why don't we invite a few comments, very brief comments and questions. There's a microphone here, and there's another one over here on this side. If anyone cares to jump up and offer any comments or questions, just please identify yourself and please be very succinct. Thank you.
Good morning, Dr. Frieden. It's a pleasure to be in your company. Jesse Mylan from Dorier Underwood and the Black AIDS Institute. You've talked a lot about international security, but I realize that the FDA does not fall under your purview, sir, but could you give a comment around food security, especially for so many importations coming from Latin America to the United States?
So the question is about food security. We get about 80% of our seafood from other countries. We get a large and increasing proportion of our fruit and vegetables from other countries. So improving the regulatory capacity of other countries is very important, but also improving the disease detection capacity is important. So identifying outbreaks of diarrheal disease or other food poisoning, this is in our self-interest. It's in our self-interest to ensure that countries that we do business with have improved systems to find, stop, and prevent the spread of disease. As an epidemic intelligence service officer, I investigated an outbreak of what turned out to be essentially traveler's diarrhea, which was contracted by a large consulting firm in Manhattan based on some shrimp that were purchased from a provider in the Gulf of Mexico. It's a very globalized world food supply, and improving the quality and the safety of it anywhere is ultimately going to improve productivity everywhere.
Yes?
Yeah, I'm a, excuse me, a physician at Emory. Also tried to write books to empower people. We had written Doc Hollywood, and one of the things I have wondered is, and this is a problem around the world, is to, in education, not just teach reading and writing, but teach and empower people to be better health consumers. In other words, we worked with the CDC on some kids' book on immunizations or symptoms that are life-threatening, so people know that. When I worked in emergency rooms, even in this country, people would come in too late and they'd be dead, and they didn't know the signs of meningitis. And I wonder if it's possible that we can even donate books that are in Spanish that relate to these topics. But it would be great if this could be a movement to start to empower people and teach them some of the stuff we learn in medical school.
Thank you.
Thank you. I think with increasing literacy, with increasing education, there's a tremendous potential for people to take more control of their own health. Part of what we do in public health is to try to make that information readily available to people so people can make more informed choices, but also to change what's sometimes called the choice architecture, so that when you go about your business and do things that are the default value, you end up healthy rather than sick. That includes drinking water from the tap and not getting sick from it, or doing other things that are just normal course of business and being able to do that without risking illness. That's fundamentally what public health is about.
Yes?
I'm Tom Watkins, a freelance writer. what do you wish had been done differently in responding to the Ebola outbreak?
The first issue on Ebola was that we didn't have in place systems in West Africa to find it quickly. That was the first and most important problem. If you compare what happened in West Africa to what has happened in the past couple of years in Uganda, in DRC, there are outbreaks of Ebola because we've trained staff, because we've trained hospital workers, established laboratories, established response capacity. They're rapidly identified and stopped before they spread. If you look at what happened in Nigeria, it's very instructive. A single traveler from Liberia went to Lagos, Nigeria, a city that has about as many people as all of the 3 countries of West Africa combined. There was an outbreak of Ebola because it wasn't immediately recognized. We immediately swung into action and we deployed the polio eradication infrastructure for Ebola response, established an emergency operations center, put an incident manager who was experienced in managing emergencies in place, flew in a large team of CDC staff, redeployed staff from the polio eradication effort to the Ebola response. Over the next couple of weeks, that group in Lagos identified more than 800 contacts, did over 19,000 home visits, identified 19 secondary cases in 3 different generations of spread, but stopped the outbreak. If that hadn't happened, the past year could have looked very, very different. Ebola could have gotten completely out of control in Lagos and spread throughout Nigeria and Africa. So that core issue of strengthening the capacity of countries around the world is critically important. And then where that isn't sufficient, the ability to surge in is important. At CDC, we activated our Emergency Operations Center for Ebola on July 9th, and we committed to putting 50 of our top disease detectives and disease control specialists into the field by the end of the month. Things moved so quickly that we had hit that 50 mark within 11 days, and by the end of the month, we had 100 people in the field in West Africa, but it wasn't enough. The global need to surge in was just greater than CDC or any other organization was able to do at that time.
Do you agree with the criticism of World Health Organization as for putting out what some call a lackluster response?
I didn't hear you.
Do you agree with the criticism of WHO for a lackluster response?
I think no organization can look back on the past year of dealing with Ebola and say we did everything right. Clearly there were serious problems with how the WHO responded initially. I think that just re-emphasizes the need we have to strengthen WHO because it is the organization that has the mandate and should be able to do a lot of the things there. There are some potential mechanisms where WHO can coordinate others. There's a global outbreak and response network that has hundreds of organizations. That network, if more vibrant and effective, we think could have been much more impactful in this situation.
Thank you.
Thank you. We'll take one final question. Ginger?
Thank you, Dr. Freeman, for coming. Ginger Floyd, the Morehouse School of Medicine, and it's a follow-up to Dr. Shulman's question in terms of the use of traditional healers, frontline workers, community health workers in these programs that are affecting us around the globe, whether they be curandandos in Mexico or, Candomblé in Brazil or traditional healers in Africa. What is how do you believe that these are, many people believe these are the right messengers. How do we ensure they get the right message? And how do we use them?
One of the really promising practices from Latin America that has been adapted in the US is the use of promotores de salud, or health promoters. There's a lot of evidence and experience about what works and doesn't work in community health workers. It's not enough to be well-intentioned. It's not enough to hire the right people. You have to ensure that community health workers are integrally involved in and part of the primary healthcare system. If they're not going to be effective. They won't be supported, they won't be trained, they won't have backup, they won't be trusted by the community, and they won't be able to function effectively. If they are, it extends the reach of the primary health care system into the community in a way that may be culturally acceptable and much more effective than some of the clinic-based services. I think in this and in other areas, to just make a final comment, there are so many areas where Latin America and the Caribbean have promising practices, best practices, real progress, where we can both extend that throughout the hemisphere, but also extend that into new problems, strengthen our security against global health threats, further improve vaccination programs and extend to new vaccine introduction, address the cancer, heart disease, and stroke problems that are now our leading causes of death and also are amenable to public health approaches of high quality, standardized, accessible care. And that's the kind of progress that I think we can look forward to in the coming years in Latin America and the Caribbean. Thank you.
Tom, last night there was a lot of discussion around what does the potential normalization of relations between the United States and Cuba mean in this broader question around capacities. And setting aside for a moment the complexities of getting from point A to point B, what would you see as the benefits and consequences downstream if the politics and some of the legislative barriers are resolved? What might that mean in your view?
Cuba has an interesting public health system. It is unique in many ways in the world. It relies very heavily on physicians and on community-based care. I haven't studied it in detail, but I've looked at some of the results. There are also remarkable implications of the economic difficulties that Cuba has had. For example, when the nutritional status of the Cuban people went down, you saw epidemics and you saw a big increase in tuberculosis. But the country has been able to turn out large numbers of doctors and to provide those doctors as a form of international solidarity. I traveled recently to Koya, a community in Guinea, where the Cuban doctors were staffing a Ebola treatment unit constructed with US taxpayer dollars and operated under the World Health Organization and African Union auspices. And I got to chat with the Cuban doctors and see what they were doing, and they were so proud of being able to contribute to the response. Cuba also has its own health challenges, as does the US and every country in the hemisphere. And the more we can share what's working and what's not, the more all of us can make progress.
Please join me in thanking Dr. Frieden. Thanks, Tom. This is great. This has been great.
Thanks so much, Tom and Steve, for that wonderful kickoff. And as a CDC alum, I am always very proud and pleased to see Tom Frieden and the incredible job that he has been doing leading the Centers for Disease Control and Prevention. So thank you so much for being here with us. The next panel that I will be chairing is a panel talking about the issues of health infrastructure in Latin America and the Caribbean. And with us, we have three incredible panelists who all have a very different range of experiences in global health and particularly in the Americas. I'm going to introduce them very briefly. As I mentioned, their bios are extensively in the program, but I will introduce each of them and have them come and sit in the chairs here, and then we are going to have a discussion. So let me first start with John Andrus, who is the Executive Vice President and Director of Vaccine Advocacy and Education for the Sabin Vaccine Institute. John, like all, has a several decade experience in health and global health. Before coming to the Sabin Institute, he was the Deputy Director at the Pan American Health Organization, where he was most recently deputy, but also held a variety of different roles there. He started his career in health as a Peace Corps volunteer in Malawi, and then held several positions at the Centers for Disease Control. So John, welcome to the panel. My next panelist is Amanda Glassman, who is the Director of Global Health Policy and a Senior Fellow at the Center for Global Development, a leading think tank in Washington, D.C. And there she's leading work on priority setting, resource allocation, value for money in global health, and has a particular interest in vaccination. She has several decades, 20 years of experience working in health and social protection programs and policy in Latin America and elsewhere, has held extensive different positions in the Inter-American Development Bank, and also time with Brookings Institute in Washington, D.C. So thank you, Amanda. And finally, Dr. Frank Richards, who is an expert in parasitic and tropical diseases and has worked extensively in Latin America and Africa. He has a 20-plus year career with the Centers for Disease Control, and after leaving and retiring from the CDC, went to the Carter Center and has been very involved there with a variety of different parasitic and tropical disease elimination programs. So I think it goes without saying that we have an incredible group of people to have a very engaged dialogue. And I'm going to talk from a variety of different perspectives. Several people have experience in disease elimination, as well as work on health infrastructure, and want to really think about how those things blend together. So again, thanks to our panel. And let me just start first, maybe with you, Amanda. And given your experience and all the work that you've done, you know, this issue of how health and development interface, and you've done a lot of work on social protection. And maybe you could start by just talking a little bit about what that means. Johnny Isaacson in his video talked about how the interface between poverty and health, and I think social protection is something that the Americas has done perhaps more in than any other region in the world. So maybe start with some of the work there and how that has helped to build health infrastructure.
Sure. Well, I think one thing to note is that even though Latin America has grown economically very rapidly over the past decade, there's still an enormous number of people who are living, let's call it, in vulnerability. So that means the very extreme poor, people who are living on $1.50 a day, have gone down a lot, less than 10%, I think, in most countries. But almost 85% of people are still living below $10 a day. And $10 is sort of the threshold above which you pass that and you're not going to fall back into poverty. It's associated with more years of schooling. And so those groups are so vulnerable, which means that if there's sickness or if there's illness, death in a family, it basically can put them back into poverty. And in even a country like Brazil, you know, the median income is still well below $10 a day. So that just gives you a sense of the big challenges that the region faces. And I think that's why a lot of the governments decided to focus on protecting families from this kind of catastrophic out-of-pocket spending on health by expanding insurance or universal health coverage systems. So I think that's been a big emphasis over time. And then you've also mentioned the cash transfer programs, the conditional cash transfer programs that began in Brazil with cash transfers to mothers to make sure that their kids attended school. And it's no more than 10 to 20% of a family's average income, but it's really made a difference in terms of nutritional status, in terms of utilization of preventive health care, and it has contributed also in poverty reduction. So those kinds of programs are basically all over the region now. The biggest one is in Mexico. They've had really great impact evaluations that show pretty unequivocally that they have changed lives.
So just to probe on that a little bit more, you know, it sounds nice. It sounds like something that, you know, kind of makes sense. Not sure we'd ever get it here in the United States, but that's another issue. That said, you've done a lot of work about actual correlations with these. Can you say something about how it has had hard outcomes that really demonstrate that these kinds of programs actually do make a difference in health, besides the fact that they're nice, they sound like nice to do, good things for people? You know, how have they actually had an impact on health outcomes?
Well, they've had a difference on vaccination rates. So kids, you know, of course, these are targeted programs, meaning they're really directed at the very poorest members of communities. So nutritional status has improved, use of preventive health care like vaccination, like well-child visits, like access to oral rehydration therapy. Those kinds of basic things were covered and did make a huge difference for the populations that did benefit. And again, they're pretty fancy impact evaluations, so we're confident about that. There have been some unexpected consequences. In Mexico, there's a slight increase in overweight and obesity among beneficiary families as the program expanded coverage. So it's not unequivocally a good thing. But it definitely has affected some of the health outcomes and utilization. It's also affected the kinds of food people eat. They're tending to eat healthier food. They're buying more vegetables, more protein, things like that. So those are the kinds of effects that we've seen measured in the programs over time.
And we're talking about health infrastructures, and a lot of discussion, Tom mentioned in his earlier comments. What have these things done to actually help to build infrastructure? Because at the end of the day, having short-term improvements, but not also building longer-term systems, really, I think we all realize we're only going to continue to have some of the same challenges. So are there things that you've learned from some of these programs that demonstrate how they can also be helpful for building long-term systems?
Well, many health clinics in poor areas are underutilized, actually. So people just don't go. So health staff is there. Maybe they're also working in the private sector. So one thing that these programs did was to incentivize the local community to go to the health clinic and demand services. And that has, in some cases, elicited a supply response from providers. So they're seeing more people. They're asked to meet quality standards. In some cases, like in the program in Nicaragua, they actually set up a new network of non-governmental organizations that were providing a basic package of health care in places where they had never had access to health care. So it does come alongside some supply investments. But that said, most governments have been investing pretty heavily in healthcare infrastructure, supply. Lots of clinics and hospitals and things like that. I think the big challenge now is not so much physical infrastructure, but quality. I don't want to change the subject, but I'll stop now.
Oh, we'll get back to quality.
Just to give you two examples of the quality problem. We just heard Dr. Frieden and Steve Morrison talk about H1N1. But the case fatality rate was double in Mexico because of the quality of care. Or breast cancer, right? Most breast cancer cases in Latin America are diagnosed in stage 3 and 4. In the United States, among Hispanic populations, the great majority is in stage 1 or 2. So it just gives you a sense of the capacity of the health system to prevent and respond in the quality of care.
Okay, and we'll get back to quality and some of the big challenges there as well. John, let me just turn to you for a minute. As I mentioned in the intro, you started your global health career in Malawi as a Peace Corps volunteer. I actually coincidentally just came back from Malawi about 3 days ago, met with Peace Corps volunteers there, and what Peace Corps does around the world I think is really incredible. But say a little bit about your experience there and maybe some of the kinds of things that you learned in that very rural environment that might be good lessons as we think about how to start using different kinds of tools to start creating more stable infrastructures for health, and particularly prevention issues.
Thank you. Malawi was my first overseas assignment. I was trained as a family physician and had applied for a number of jobs overseas, and I didn't have the experience or the MPH or other credentials, so I ended up joining Peace Corps to get the experience and find out if global health was something that I would be interested as a career, and it provided that for me. The defining moment in my experience in Malawi was being a clinician, being highly involved with curative services, spending all my time in the OR, was seeing the opportunity that prevention had in building primary healthcare services, health access, that I had not experienced or had been instructed in medical school. The district hospital was a 66-bed hospital built in 1908, had no running water, had no electricity, did not have a blood bank. So a mother in labor with a transverse lie in a village, her only access to the hospital where we could help her was an ox cart, and oftentimes her uterus would rupture. So we were confronted with this emergency, and we'd have to go to the school where we knew the children blood type, and if we were lucky, we would get a match, and in some cases we were able to help, and many situations we were not. But it was a defining moment for me because 1986 was the year of immunization. I had, in the first year, trained 3 Malawians to do complicated obstetrics and was free in the second year to focus more on this prevention. And I was learning by the skin of my teeth, and we had this bolus of resources to help train our staff to do immunization, to improve the coverage that was below 40%. And I was fascinated by these health workers who had to take call 24/7, who came in on weekends to round on patients who were probably paid not more than I was as a volunteer, but who were just enthusiastic about preventing disease that they saw every day, killing children, measles, pertussis, diphtheria, and so on. And I was fascinated by this combination of energy and commitment with the technology. And from there, I think over my career, I continued this learning about how we can use prevention to link to primary care services, extend it, as the colleague from Morehouse inferred in her question, to community. It's been, I think, an amazing opportunity. The nice thing about Latin America and the Caribbean is that they're oftentimes the laboratory, the testing ground for developing the tactics that will help improve access and a broader spectrum of healthcare services that includes both prevention and curative side of things.
So, you've spent a lot of time, all over the world, India, Africa, and then extensively in the Americas. If you think about what some of the biggest obstacles are, and you've done a lot in particularly immunizations and some of the disease elimination work, what are some of the obstacles around moving from there to actually getting health systems in place? And what are some of the lessons that you learned along the way that you think would be important lessons learned to think about this whole issue of really using what we have to really think about building systems?
Great question. Two things come immediately to mind. One is that I'm a believer in the strength of when adequately trained, when adequately supportive with supervision and management, the power that the human resources have, not only within the structure of the health system, but again, within the community. And so I think that's a lesson learned that we often overlook, how to sustain and build on that human capacity. I think we have an opportunity with the polio legacy to do that in many parts of the world. The other that I've noted that often strikes me, having had the opportunity to work in various regions, the difference between Latin America and the rest of the world. In my mind, there's this culture of prevention that you see in Latin America and the Caribbean, and political commitment that you don't always see in Africa and Asia. That's not to say it doesn't exist, because if we remember the global measles initiative for Africa, in 6 years, 6 or 7 years, not too long ago, some 13 million deaths were averted with the activities, measles vaccination and surveillance and so on in Africa. So there is that, and that was a political commitment of ministers of health in Africa who recognized measles was a big killer of children. And you see what happened in India with polio eradication. So those are examples of successes. I just would like to see that expanded. And I think if it's coupled with that human resource element, there's an opportunity to move mountains.
And maybe we'll get back to the topic of political commitment and leadership, because I think that is, a huge issue, not just in the Americas, but as we think about health globally. But Frank, let me turn to you for a minute. And you also had kind of a early experience that led to your thinking about global health. And maybe you could say a little bit about that experience. I think it was Brazil, how that helped to cement your commitment to health in the Americas. But also, if you think back to the Frank Richards of then to now, what are some of the big lessons that you've learned as you have advanced in your career? And what would you tell your young Frank Richards as a medical student in Brazil, the lessons that you've learned now, or maybe it was even before medical school, but.
Thanks, Aline, and thanks to the sponsors of this very interesting conference. Just my story goes back to an experience, as you mentioned, as a medical student. Actually, in
you don't have to sell the date.
I'll tell you. 1977, when I took a course as a second-year student in tropical diseases and got extremely interested in parasitic diseases because of the social, cultural, and political and environmental linkage to health. And these were diseases of poverty that we could do something about. And it was solidified when I had an opportunity as a senior medical student to spend almost 6 months in a rural village in northeast Brazil in the state of Bahia, which, if you've ever been there, is largely African. The preponderance of slaves in the Atlantic slave trade came to Brazil. And I was particularly interested in that experience and the number of conditions that were there that had come from Africa. I think it's just a reminder that the interesting thing about the Americas is this coming together of the indigenous peoples, the Europeans, and the Africans, and the amazing deaths that occurred, numbers of deaths from the diseases that were imported, some of which, smallpox and measles, are basically gone. But then some conditions like lymphatic filariasis, schistosomiasis, river blindness, which are legacies, which is really, I'm very involved and passionate about trying to work toward ending these conditions in this hemisphere, and also the opportunity of showing an example of what can be achieved in Africa. But later, so I had this period of time in Bahia, but then later I'm another graduate of CDC. So I spent 5 years in Guatemala, 1987 to 1992. And that was at a time when Merck decided that it was going to donate the medicine Mectizan for as long as necessary, as much as necessary, to try and end river blindness called onchocerciasis. It's the first major pharmaceutical donation. Many other pharmaceutical companies have followed suit, and it's a good story about pharmaceutical. We have so many bad stories about pharma. This is a really good feel-good story about pharmaceutical donations, and the donations have now come in from a number of different companies to, in my field of the neglected tropical diseases, the neglected parasitic diseases, you're looking at opportunities to make major impact on diseases of the poor. So under the topic here, and then in Guatemala I had an opportunity to work on the early distribution of those medicines. And the thing that really was a very important moment for me when we were working on developing health educational materials, and we were doing knowledge attitudes and practice surveys to figure out the best way to communicate what these medicines were about that were going to be distributed door to door in these very poor communities. And so the question that we asked was, what are the health problems of this community? And I can remember it like it was yesterday. We were in a thatched roof house, dirt floor, chickens walking around. We asked an old guy, what are the problems that afflict this community? And he said, fíjese que esta pobreza no se escapa. Can you imagine that this terrible poverty can't be escaped? That was the response to a health question. And it was extremely poignant, and it resonates with me to this day. And I really hope that when we talk about the issues in the Americas and the progress that the Americas have made, et cetera, that we don't fall victims to the tyranny of averages, and that we look at the average getting better, and we look and we forget that the extremes are getting greater and greater. Our own country, the United States, it's the same thing. So let's not forget the extremes, and let's not forget that there are many people, marginalized, often indigenous, often Afro-American communities, which are being left behind, and we cannot forget when we look at these averages that they don't reflect the entire situation.
Yeah, no, it's a great point, and I think one of the issues I want to ask all of you what you think about how to make sure that there continues to be a focus of health in the Americas, because I think the law of averages, most of the countries in the Americas now are considered middle income. Donor resources are no longer pouring into the Americas like they used to. And I think it is a very challenging period as we think about the reality of scarcity in the world. So it'd be useful to hear all of you kind of give your impressions around, where is the attention? What is it going to take to get the kind of political will to focus on the issues of health in the Americas? And in that, and you touched on the private sector, I think thinking about what's the right blend, if you will? Who are the different actors who could have an impact on really looking at some of these issues of health? So, a broad range of questions, but I think this issue of how do we keep the attention on, how do we make sure that we keep the focus where it should be, and who are the different actors who really can help think through some of those issues? So, start with you, Amanda.
Yeah, I think one way to look at whether something is a priority or not is how much governments spend on healthcare. And there are two kinds of countries in Latin America. There's Costa Rica, Argentina, Panama, Uruguay, Trinidad, where health expenditure has taken off. We're talking about getting near $1,000 per capita, which doesn't sound like a lot to a citizen of the United States of America, where we spend 70% of our GDP on health. But this is explosive growth in real terms in terms of health spending. Why?
And percentage-wise, what is that?
It's like around 8%. It's getting up 8, 9%. They're, in a way, on a trajectory like the United States. There is enormous demand for health care. These are aging populations. These are urban populations. And their challenge is, how can they decide better what they're buying in terms of promoting health? Because they still do have these pockets of people who are not being reached. But for most of the countries, including a country like Peru, they have been flat on public spending on health care over the past 20 years, in spite of incredible economic growth. And in those countries, you have to say to yourself, what's going on, right? And I think It does have something to do with mobilizing demand. Most people are using in the private sector in those countries. I think they're voting with their feet because the quality is poor in the public sector. And so that is really a decision for governments to make. Are they going to invest, or at least are they going to create mechanisms so that people can prepay for health care instead of paying out of pocket? Doesn't matter if the private sector is involved or not, but the issue is, can they improve quality of care? Can they expand coverage in the way that they should? And I think that's all about what the population wants, and voting, and making health care a political issue for people. So I'll stop there.
Great question, Helene. A couple of things come to mind, and related to my most recent role before coming to the Sabin Vaccine Institute. I was formerly the Deputy Director of the Pan American Health Organization, and I was pleased to see the Senator in the introduction refer to the formation of the Pan American Health Organization in 1902, and it was based on collaboration, wealthier countries helping the less affluent countries tackle amazing challenges at that time, notably yellow fever. And I think that spirit needs to be carried forward. I struggled in my last role to mobilize support for Latin America because of this tyranny of averages. And we have to get beyond that, because we are a family of nations in the Western Hemisphere. These are our neighbors. And the more we can remind ourselves of that, there are other opportunities as well. I mentioned earlier that Latin America often serves as the laboratory for public health innovation. Polio, measles, rubella, congenital rubella syndrome, from my experience, has certainly been a testament to that, and sure in other areas of public health. So we somehow must get over that they're okay. We must focus only on Africa and South Asia. That if we don't keep our eye on the target here in our own neighborhood, it could come and hurt us all, I think, potentially. I'd like to just briefly comment on the public-private partnerships as well, because I think that's an incredible opportunity. And I think in the world of immunization that I'm involved with, it's been an amazing collaboration, because you can't, the challenge is getting these new life-saving technologies to those who need them most. Cervical cancer is an excellent example. 80% of the women who die of cervical cancer come from areas of poverty in the world. They come from developing countries. And so that vaccine needs to be made available to those who need them most. And I think the more we can work on those partnerships, the private sector is critically important, as one example.
I think that it's really important for us. I'm an epidemiologist by trade, and we epidemiologists have to have our definitions straight to make sure that our point of departure is the same. And I think when we start talking about health care, access to health services, points of departure change very quickly. When you ask somebody what is primary health care, in the United States, you would say, well, I mean, it's the first provider. It's the person who's, you have primary health care specialties versus specialists. So this is where you come in for general care. You're the gatekeeper to other services. You're the gatekeeper to referrals. And that's what a lot of people think about a primary health care system. Whereas in poorer areas, primary health care can be much more focused on access to the most important kinds of services that can have the greatest impact on lives. Maternal health, vaccinations, treatment of diarrhea and pneumonia, emergency services for fractures or a snake bite, and then outreach for water and sanitation. People think about that as primary health care. And those are, and so very often there's crosstalk when you're discussing these things. And I think this is a big risk that we're hearing in all the discussion in the Americas when we talk about the tyranny of averages or the extremes. Are we talking about the great new approaches for universal health care and access in those senses to prevent catastrophic illness, Or are we really talking about outreach to the rural communities, to the urban slums, to the most marginalized and the lowest income groups? So, you know, both of those have great value, but I really hope we're careful when we talk about access to services to make sure we're talking about both. And I think Tom Frieden got into some very important issues, because we also have this dichotomy when we talk about the health system where I think he mentioned we always want to think about clinical services. This is clinical services. No, part of the health system is the public health system. Right. The workforce that's involved in reporting and response and the ability to surge, the ability to track down TB cases, all of those sorts of things. I really hope that when we talk about access of health services, that we don't forget that the different arms of a good health system that must indeed include investment in public health and reaching the extreme poor.
So let me just, staying on that, you know, that has been, you know, much of your life's work is really focusing on neglected tropical diseases and diseases, as you said, diseases of the poor. And in the Americas, you know, there has been this big shift to chronic diseases, non-communicable diseases, but the job is really not yet done around, you know, ridding the hemisphere of some of the diseases that you work on. What do you think are some of the biggest obstacles to finishing the job of really getting rid of some of these neglected tropical diseases? And do you have concern that the focus is going to shift because of the priority on non-communicable diseases and the job won't get done? So what is it going to take?
Well, I think the challenge that you get into when you're dealing with people who really have very little political voice is that their diseases become forgotten or are forgotten. The concern for investing, even when you have available tools, in this case, free medicines, good medicines, free medicines, I think is the really big challenge. And as progress is made, I'm very, very interested in elimination and eradication as public health strategies. It was great to hear Dr. Frieden talk about that. Eliminating from the Caribbean, malaria from the Caribbean, lymphatic filariasis from the Caribbean basin. My great interest is eliminating river blindness from the Americas. We're 95% there. But the issue is, no matter how lethal the condition, as the prevalence goes down, as the incidence goes down, as the DALYs attributed to it go down, then people become complacent. I think I'm very, very worried about the approaches where economists begin to tell you that you can always get a better buy for your health dollar, more value for money, going to conditions that have greater impact, as opposed to finishing the job and looking at agendas that are not yet completed. And so complacency is a big problem, particularly when there are diseases that are not like Ebola, that will not strike fear in the worried rich that this is going to invade and result in some sort of horrible situation of the last ship, or whatever the concerns that we are about some catastrophic Armageddon. So this is my real concern, complacency.
Yeah, and I guess in many ways, as you talk about it, it really is a social justice issue. You know, you can do the economics of it, and maybe the economics may not point you in that direction, but if you think about it from a social justice lens, you know, there ought to be a commitment to finishing up the job of some of these diseases that do disproportionately impact the poor. As somebody who has economics in the background, you are
hard to attack.
Well, I mean, I think these are ethical choices. They're choices about how governments are going to spend scarce public resources, and you know, they're facing people in facilities asking for treatment for things, and I think you're right to point out that this is a difficult problem. But I think one issue is the fact that most of these countries are federal countries. They are more like the United States than they are like the UK. Okay, this is not like an NHS situation where, you know, there's a central government and I plan. You know, in public health, we love the vertical programs, and we constructed the public health programs that way. But most countries in Latin America are federal countries where all of the money is at the state or province level. And so I think the budget treatment of public health programs in the context of federal systems is something that really needs to be looked at very carefully. And I think something interesting was done in Brazil, where they would give a sort of incentive payment or prize to the states that went faster on eliminating lymphatic filariasis, for example, which is one of the neglected tropical diseases I think that we all care about. So there are ways to focus on public health in those settings. But one big obstacle is that the surveillance systems are still so weak, you really have no idea how many cases there are. I think this to me is the big problem. You can't even decide on resource allocation the right way if you don't know the prevalence or incidence of things. So that just relates to like these core public health functions that we need to incentivize, you know, the sub-states and provinces. We have the same problem in our own country, obviously. So we should take some of that know-how and worry that we do here to share with our colleagues in Latin America.
John, you have had a lot of experience with surveillance systems. Your work in measles, rubella, et cetera, elimination work, you know, you've thought about how can you use some of these vertical programs in a way that help to strengthen things like surveillance. Maybe could you say a little bit about that?
Thank you. I was just thinking as the discussion was ongoing about that, because I think it's the challenge, as you posed the original question, actually is an opportunity. And the opportunity is to strengthen surveillance, as you mentioned, but the opportunity to integrate your interventions. And it must be done proactively. It can't be a passive process. So in the case of the elimination of congenital rubella syndrome, for those that are not familiar with this disease because it's been eliminated in the Americas, it's a syndrome that occurs in babies born to mothers who are infected with rubella virus in their first trimester of pregnancy. The risk of having a baby born with this syndrome, if the mother is infected within the first 10 weeks of her pregnancy, is above 90%. And the syndrome itself is a constellation of various signs, including mental retardation, autism. These are things that are difficult to measure, so disease burden is often difficult to measure with congenital rubella syndrome. But the classic medical school textbook often describes the triad of blindness, hearing loss, and cardiac defects, but we forget the other problems that I've already mentioned. Now, there are other causes of congenital anomalies, and one benefit from this initiative has been now the standard of care in all countries is to do torch titers. These are titers on all pregnant women. These are tests drawn to test for other causes of congenital anomalies, and that can be caused by, for example, toxoplasmosis or syphilis or other cytomegalovirus. And so to test those and to be better prepared to either treat that baby, provide preventive services. And another example is now the standard of care is to test children born in hospitals, a very simple hearing test before they're discharged home after birth. And because the sooner you can identify those children with hearing loss, the sooner you will be able to mitigate the risk that that child has huge challenges in the life ahead. So good examples, the surveillance systems, the fact that the laboratories for elimination of rubella and congenital rubella syndrome, measles, they're built on the foundation of the polio efforts and other infectious disease efforts. So that forward thinking, being proactive, how can this, Tom Frieden gave the example, the response to Ebola in Nigeria. The benefits of that are far-reaching. Those are some immediate examples. And I think these are opportunities going forward. And Latin America and the Caribbean has so many lessons learned. One call for action that I would hope comes from this meeting today is that we do a better job of exporting those lessons learned.
I don't see the card where it says where I'm supposed to switch to the audience, but I have the feeling that it's probably about time. I'm going to ask one more question, and then if people in the audience have questions, please start lining up at the microphone. Steve, in the last panel discussion with Tom, started the question around Cuba. It's difficult to talk about that, especially when you're working in a government agency, but where we have not had, as CDC, the opportunity to have perhaps as much engagement. I know it's an area that you have spent some time thinking about, and it's hard to talk about the Americas with everything going on today with the potential change in relationships between the United States and Cuba, to not think about what examples come from the Cuba experience. Any of us who have been in global health have been to other countries where Cuban doctors have played a real part in kind of health diplomacy around the world and helping to strengthen other health infrastructures. So maybe starting with you, say a little bit about what do you think the lessons are for Cuba? What do you think the change in some of the diplomatic relationships between the U.S. and Cuba might offer in terms of ways of better collaboration? And then would love to hear others' comments as well on the issue of Cuba.
Mm-hmm. Well, I think I'll leave for the others to talk more about what are the lessons learned from the Cuban approach to healthcare. But one thing that I've been thinking about a lot is if Cuba opens, and Cuba is opening gradually, what will happen to the Cuban health system that seems to have gotten good results over time? And, it's clearly an area where there's already been cooperation with the United States. Dr. Frieden just talked about an Ebola treatment unit built by the United States, staffed by Cuban physicians. So my question is, are we going to let other organizations like the Andean, there's a bank it's called the CAF, Comunidad Andina de Fomento, or something like that. The CAF just gives money and not technical assistance and doesn't mobilize all the member countries' expertise, whereas the Inter-American Development Bank, where the United States plays a role, where the Europeans are there, where all the region's governments are there, the IDB could be there with PAHO working on health in preparation for an opening period. And it shouldn't be the case that US legislation wouldn't allow us to do that. And I think US companies are already starting to operate in Cuba. I think it's just an agenda that serves us all, to look out for the health system and hope that we can protect it. And I should say, just as a little footnote, as a child, I lived in Cuba because the US opened relations with the Cuban government in 1976 under the Swiss interest section. And I just am so interested in it and hope that we can save all the great things that were Cuba before things go very capitalist. So, thanks.
John.
As a CDC epidemiologist seconded to the Pan American Health Organization back during the polio eradication efforts in the Americas, the Soviet Union disbanded. And as a consequence of that, the polio vaccine supply to Cuba was interrupted. And this is during a time when we were quite concerned with the virus respecting no borders, whether the children of Cuba would be exposed to polio outbreaks. And Cuba, you may recall, was the first to eradicate polio in the Americas. And you often use that experience to help motivate other countries. So the PAHO was able to mobilize the Rotarians in the Yucatan who actually have family relatives in Cuba to support the reinitiation of polio vaccination through other sources to protect the Cuban children. And being engaged and involved with that, I had a personal sense of the incredible opportunities and lessons learned that Cuban health, particularly immunization program, has to offer, and I think that will continue. I think, and we have opportunities to nourish that. There is they manufacture a vaccine, and there are lessons learned from there for regional independence, I think, and supply of important vaccines. So it's wide open now. Before there was this lid that was very difficult to establish those collaborations, and now I see, and I share Amanda's concern that there's some risk, but hopefully we can get it right.
Rick?
Well, I think we're all familiar with how the health of the Cuban people was enormously helped by the revolution, and I thought, John, you were also going when you were talking about the fall of the Soviet Union, also how health indices changed there for the worse, so from the general perspective, my general perspective, and you touched on it in terms of equity earlier, I really think we'll be much better off when our health decisions are made thinking about equity and thinking about ethics as opposed to thinking about economics. I'm realistic enough to understand that economics are very important, but I'm hoping one day in the future that the ethicists will make our decisions regarding health rather than the economists.
All right. On that note, let me turn it to the mics, and I would just say, and I think John, you touched on a little bit the issue of collaboration. When we think about Cuba, a lot has been said about how Cuba has put in place a system that thinks about equity and has really thought about not only equity within Cuba, but also how to extend some of that around the world. On the other hand, I think there's a lot that we could also our expertise will also be helpful. And so I think this notion of the collaboration, it's not a one-way street. I think there's something to be learned in both regards. So, yeah.
Well, just to say, we don't really have a great handle on data in Cuba, so it's very hard to say what's happening with the health system and health outcomes right now. And I think, it will be useful to engage more, to understand what's really happening in terms of disease, in terms of the infrastructure and its capacity to deliver, in terms of access to medications. These are all things that are somewhat unknown, maybe known to PAHO, but for the rest of us, I think, especially in the United States, it's really not clear what the status of the system is right now.
Yeah. First, Mike over there, and if you want to just say name or affiliation.
That me?
Yeah.
Okay. Good morning. Thank you all for speaking. My name is Ashley Johnson, and I'm a recent graduate of Agnes Scott College, and I studied public health and anthropology. My question is directed at Dr. Andrus. In regards to your work with cervical cancer, particularly in Brazil, there are cultural constructions of identity, specifically in like favela culture, that prohibit women from having adequate access to vaccinations. So I'm wondering, what are some ways that organizations have worked around these cultural constructions of identity to increase access to vaccinations?
I'm having a hard time hearing. There's an echo and.
Yeah. You were talking about the standards for cervical cancer vaccination.
Yes. In favela culture in Brazil, women are often prohibited from obtaining vaccinations because of cultural beliefs of how women should take care of their bodies and their health. And so I'm wondering, what are ways that organizations have worked around these constructions to increase vaccine availability?
Okay, so in Brazil, the cultural barriers to women getting access to cervical cancer. Yeah.
Yes.
Sorry, there's a bit of an echo, so we're not hearing
the
questions as well. Plus, we've got these lights in our eyes, and so.
And my hearing is not very good. So, but thank you for the question. Cultural, behavioral issues are a huge impediment, not only to HPV vaccination, but to a number of other vaccinations, particularly as you expand the childhood program into a family immunization program. And that's occurred, I think, over the last decade in particular. In the old days, it was focused on getting those kids 1 year and less vaccinated with the traditional vaccines, and now a number of events have helped us expand that across the lifespan. And as we do that, those opportunities also pose certain challenges because of our less evolved or less experienced approach to how do we reach these communities or people in the older age groups. Brazil has been highly effective on using the opportunity to vaccinate the elderly with influenza vaccine. And what they do is they do a campaign during vaccination week in the Americas, which is the last week of April every year. And on a yearly basis, they reach some 15 million elderly with influenza vaccine.
Define elderly, because some of us are getting close to that.
Some of us are elderly.
Including myself, which I can't hear. But, you know, above 60 years of age, as an example. Because it is I'm sorry.
That's all right, well.
So that's an example where some of those barriers have been overcome. With HPV vaccine, you've noticed, you've highlighted some concern even with successful intervention. There's always the risk of side effects, particularly behavioral side effects that have set certain programs back because of clusters of, particularly in school vaccination settings where that's been a challenge. But behavior to get an adolescent and the family to ensure that the adolescent is vaccinated before the onset of sexual activity for a disease that's not going to occur for 20 years is a challenge. And so that even reinforces the need to integrate the approach, because women will continue to die prematurely of cervical cancer even with a successful implementation of a vaccination program. So it reinforces the notion of an integrated program with better screening. And there's some new opportunities with better screening. Visual inspection with acetic acid is an example where you can screen and treat actually in the field on one visit. So I don't know if I've answered your question completely, but I think I've hopefully used it to bridge to the other challenges with HPV vaccination and some of the lessons learned.
Yeah, and just on HPV generally, you know, here in this country, a lot of controversy about whether or not it should be given. Does it encourage early sexual behavior, et cetera? Are you seeing any of those same sort of challenges in other countries in the Americas where this whole issue of giving a vaccine to protect against the sexually transmitted diseases runs up against, you know, cultural norms and those sort of issues?
Yes, and it varies by country, it varies by community, which even makes it more complex.
Yeah, were you gonna?
Someone over there.
Yeah.
If you want to alternate.
Next.
Hi,
We're
Dr.
just
Carl
gonna alternate
Capaluto.
between the microphones, and we can't see very well because of the light, so.
Not much to look at, don't worry about it.
I see a shadow of a person.
Dr. Carl Capaluto with MedShare. Climate change is real, but questions remain. What can we do about it? What will it cost? And will it change anything? And this is directed toward Ms. Glassman, talking about value for money. How do you compete for oxygen with world leaders and organizations when we have things now that are effective, such as clean water, low-cost medicines, oral rehydration, vaccinations? How do you compete for time, airtime, if you will, when that is such a political or social issue that we really don't know what it's going to bring us? Thank you.
Value for money? Well, I mean, I think what you're asking about is how do sort of prove what we know to be quite effective, proven cost-effective, existing technologies, how do they compete in a space against new technologies or emerging demands and things like this? And I think probably a lot of the countries, when they're considering they're very focused on new technologies because that's where there are demands and that's where you'll have pressure from external sources. There's also a phenomenon called judicialization in Latin America, where people are going to the courts to demand medicines that are not covered, for example, under benefits plans that might be financed by government. So there is a lot of competition for scarce resources, and I think the answer is that countries need to set up transparent, fair, evidence-based processes for deciding what's in and what's out for public subsidy. And they need to make sure that the basics are there first. And the basics are public health, the basics are primary health care, but also the basics are new technologies that are really going to be cost-saving or cost-effective. I think if you look at the different entities that are making those decisions in countries, there's variable performance. None of them are particularly transparent. They've been really technocratic exercises. They don't consider, one thing that Chile has done that I think is so interesting is to start from the health problem that they'd like to solve. So they said, depression is a leading cause of burden of disease. Let's look at who has access now to what kinds of interventions, and how can we design a set of care guidelines and prevention guidelines that we could fund for everybody. So I think that's really an interesting way to look at this issue rather than sort of passively waiting for someone to show up with an application for coverage for public subsidy. So that's an encouraging trend, and I hope we'll see more of it.
Next.
Allison Fussell, Child Spring International. I applaud the River Blindness Elimination Program. Love that word, elimination, especially. So kudos to the Carter Center for all that work. Could you talk a little bit more about the intestinal worms, or STHs, in Haiti, and how a small nonprofit that helps children in developing countries get surgeries can help a bit more in that area?
Well, again, I think I heard talk about the soil-transmitted helminth, the intestinal worm issue in Haiti. I'd say that one very nice linkage that is happening between the lymphatic filariasis elimination effort on the island of Hispaniola and the intestinal worm effort is that the medicines that are given in mass distribution campaigns, safe and effective medicines donated by GSK and by, in this case, a medicine called diethylcarbamazine by Eisai, the albendazole from GSK is also effective against soil-transmitted helminths. So this is an opportunity for the proverbial killing two birds with one stone, and not so innocent bystander from the impact from this effort is really knocking down prevalence rates of intestinal parasites, which are very, very important hindrances to growth and development in preschool and school-age kids. The issue is, and we touched base on this from the polio and other eradication elimination campaigns, is when you have built this outreach structure, when you've built this effort, and you're approaching you're working yourself out of business by definition in an elimination program. What you don't want, what you want to do is to find a way to maintain the infrastructure, the appropriate infrastructures that you've put together to do other things. And this requires really quite a bit of creativity and quite a bit of discussions in selling a system that you've set up. In this case, you can talk about polio and the laboratory networks, et cetera, to continue to provide services to the public health system. And these sorts of creative partnerships and positive advocacy for what's there and how it can be used elsewhere is a very big challenge to elimination programs.
Dave Addis, I know, is in the audience somewhere and has been working on children without worms. Okay, maybe you might want to say a little bit about that. I know you've done a lot of work on worms in Haiti. So if you don't mind if you have any comments on the last question.
With apologies to my colleague here. Yes, thank you very much. And I applaud your interest in this area of intestinal worms. I'd be happy to talk with you offline. As Frank had said, the medicines for intestinal worms, at least for school-age children, are donated by the World Health Organization, actually ultimately by the pharmaceutical companies GlaxoSmithKline and Johnson & Johnson. The preschool-age children and women of childbearing age do not have a donated product for intestinal worms outside of these other programs, the elephantiasis program. I think the key for NGOs interested in this is to coordinate efforts with other efforts going on, particularly the government-led efforts. We have some reports from Haiti that there are some areas in which children are undertreated. There are anecdotal reports that in some areas children are treated excessively because of this lack of coordination. So I think it's very important to try to coordinate efforts with other actors in the field. So, but we really applaud your effort, and I look forward to talking with you.
Great. Now I'll give the microphone back to the person who was first in line. Thanks.
Good morning. Jaime Altamirano, medical epidemiologist with CDC. In terms of national health infrastructure, it is important to consider, besides the primary care programs and the primary interventions, we could set a parallel system of capacity building system that will support the primary response system. And this capacity building will secure continuity, sustainability, quality. But unfortunately, developing countries, some of the developing countries have the capacity building is broken, or actually in some cases not even existent, because they put all their funds and resources into primary care response. I would like to just bring maybe to your criteria what you see in those countries, and also highlight the importance that international health, international assistance should focus more than assistant primary care response programs to assist capacity building into the country. So when we leave, the country will be better off instead of just assisting just temporarily solutions. Thank you.
Well, I guess I would say I worked for many years at the Inter-American Development Bank and also watch what the World Bank does, and I'd say most of the lending operations that are financed by those organizations in Latin America include huge capacity building components. I think the trouble with capacity building is we never define it very well, and it's hard to say exactly what the outcome is that we would like to support, and as a result, it's hard to get governments to pick up those components, right? So what is it for, and how can we show results, I think, is the big issue going forward. And so in general terms, yes, capacity building is important, but then the question is for what and for what purpose? You know, information systems seem to me to be a very important investment to make, and there have been a lot of bad investments made and a lot of problems with those systems. So, you know, you can imagine doing something better, but we need to define what is it that we want to see from the information system. Do we want, you know, electronic patient records? I heard that in Haiti, actually, they have an electronic health record for most citizens of Haiti that we haven't been able to figure out in the United States. So, I mean, there is good stuff happening and also things that haven't worked, I think, as well as planned. But you know, certainly in public health capacity building, there have been regional initiatives, never adequate, but could be better.
Yep.
Just to add to that, one of the things we've been working on for some time now is to strengthen national capacity to make evidence-based decisions for new vaccine introduction. It was a program that we call PROVAC, led by PAHO and other partners, CDC and Sabin. And the idea there is to use South-South cooperation, use the existing expertise so that the studies done to evaluate cost effectiveness of certain interventions are done by the national expertise, owned by the national program that will lead to and link to the sustainability issue you mentioned. So the ownership is critical, and having the national capacity. It's the antithesis of bringing in outside consultants, parachuting in to do the studies and then leave and publishing. This is done by the nationals, and it really links to the ownership issue I mentioned. So that's just one example of what we've tried to do.
Let's go to, I think we have one more, or is it, yes?
Yes, I see.
One, okay.
All right, I'll be quick.
We'll take the last question.
Okay, my name is Ray. I'm from Emory University, and my question is regarding, when I look at Latin America, it looks like the burden of disease is largely chronic disease. And yet, when we talk a lot about the health sector, we seem to talk about like the health, just the Ministry of Health, as opposed to looking at Ministry of Justice or Ministry of like, or whatever, like agriculture. The other industries that where a lot of the chronic disease seems to be rooted at. I guess when we interact with like stakeholders in the country, what would you suggest is a good incentive to get people to talk to each other, like to have the Ministry of Justice or other non-health ministries collaborate on issues regarding chronic disease?
Great.
Well, this is branded the social determinants of health by our World Health Organization colleagues. You know, like all governments, and many of the aid agencies and banks, we operate in silos, and it's very hard to get cross-sectoral programs done. There was an initiative around the time of the WHO Social Determinants in Health Reports to try and program better across sectors. I believe Chile had some presidential first lady level commission. But I think there has been success, for example, in the transport sector. A lot of the transport loans that I saw at the IDB, for example, were starting to be rationalized based on lives saved. And they were even doing a return on investment that looked more like cost effectiveness in healthcare than it looked like an investment project. So there is some thinking about that, or there's a Healthy Cities project in Brazil that's quite interesting, that focuses on lighting and sidewalks and things like that as a way to improve safety. Also, citizen security is an extremely hot topic that obviously in our own country as well, where they're looking, you know, how can they make policing better? How can they take a public health approach to violence instead of a more punitive, judicially based approach? So I think there's a lot of interesting things going on. None of it totally satisfying, but I think we're just at the start of that whole movement.
John.
Just to put another spin on this, I know there was a study done in Latin America showing that if you decrease smoking prevalence by 20% and you increase access to basic primary health care medicines, for example, hydrochlorothiazide against hypertension, you increase access by 15%. You do simple things like this, you have the opportunity in the next 10 years to save 3.2 million lives. And Charles Shapiro last night at the dinner said that the challenges can at times seem undaunting. But if we think of the opportunity that intervention has, and the opportunity it has, particularly with tobacco, to link with other ministries or other sectors, as you inferred in your question, tobacco will not be just an individual decision. There's legal laws and other public health policy interventions that will greatly reduce prevalence. We know that without going into specific. So as an example of where we could use that as a starting point and then bridge to the other sectors to be sure that at the end of the day, we take that opportunity to save 3.2 million lives.
I'd just like to bring into, we have a number of ambassadors and former ambassadors here, just the importance of the political sector, particularly when you start talking about intersectoral approaches, getting water and sand, education, health, agriculture, you know, sort of the all health approach. All of these things are very, very important. In elimination campaigns, eradication campaigns, you get into cross-border issues. And that begins to bring into the Ministry of Foreign Affairs, the Department of State, the Ministry of Defense. And sometimes we've learned very well from the Carter Center and President Carter's unusual access of how powerful getting the head of state involved. And so I just don't want to forget, we've talked a lot about economists, but I want to also talk about the politicians and how very important they are in making some of these things work.
Great, thanks. And I think we are at the end of this session. I think several of the themes that came up we will probably touch on again in other panels. I think, you know, your ending comment, Frank, about, you know, essentially political will and how important that is. I think all of you talked several times about how important it is to think about building core infrastructure, and that infrastructure is not about buildings, it's also people, and making sure that we're thinking about getting the outreach and making sure we're getting to people, as well as thinking about people coming to facilities particularly. You know, I think your focus on making sure that, you know, countries are thinking about what are the needs first, and building on where the needs are, and some of the other themes that I think came out very, very nicely in this panel. So I just want to, again, thank the three of you for what I think was a very, very stimulating discussion of a wide range of issues. You bring lots of years of collective experience. You also, John, have now introduced most of us to the fact that many of us are now elders, or part of the elderly population. So. Thank you for that, too. Anyway, thanks to this panel for I think, a very wonderful discussion, and thanks to the audience for your great questions.
Good morning. We're going to start our second panel, and we'll give folks a chance to get settled in with their coffee or get their seats. This panel is entitled Addressing the Rise of Non-Communicable or Chronic Diseases, and I think it's a very nice extension of the words we've heard this morning about health security and infectious disease, in that there's probably more commonality in terms of addressing health problems than there are differences. Whether it's an issue of an infection or a chronic condition, you need to have capacity, you need to have surveillance, you need to have data, you need to have experts, you need to have the community involved and on board. So we see this as a continuation, but also a very special opportunity, because with the World Affairs Council's presentations over the last few years, haven't had a chance to talk about chronic disease or non-communicable disease. And as you all know, this is assuming a larger and larger burden of morbidity and mortality around the world. So today we hope to address some of these issues, particularly from the view of public-private partnerships and the role that businesses can play in advancing chronic disease prevention and control in Latin America. We have a spectacular panel of leaders from a variety of countries and experts on the topic of NCDs. The way we're going to run this, I will introduce the speakers. Each speaker is going to speak for no more than 8 minutes on their experiences in Latin America. And then we'll open it up for a dialogue like we've seen in the previous panel, and open it up for questions from the audience. Last night at dinner, Helene reminded us that we just don't want to hear the same old, same old. We want to be explicit about issues of tensions, disagreements, unsolved issues and challenges in terms of implementing chronic disease control programs or working in public-private partnerships in Latin America. So please be candid in your remarks, and we look forward to comments and suggestions from the audience. Our first speaker is Thomas Boyke. Tom is at the Center on Council on Foreign Relations, and recently, did you bring a copy of your book with you? Yeah.
I believe so.
You can't wave it up with you, that right? But Tom was the lead on a book on the emerging global health crisis, which is, I would refer to it as a blue ribbon report on the rise of chronic disease, its implications for global health, and I think it's going to be a very influential book in Washington. So Tom is going to give us set the stage, provide context for why this is such a problem in Latin America. And then our next three speakers, Dario, Fabio, and Jacob, they represent the private sector, and they're going to share their perspectives on NCDs in Latin America. They've been asked to use their corporate experience to describe the opportunities, challenges, and roles that corporations can play in advancing NCD prevention and control in Latin America. So, Tom, let's start with you.
Great. Well, thank you for that kind introduction, Michael, and thank you to the organizers of the conference for having me. I should start out by saying, although this panel is devoted to non-communicable disease, I have a 2-year-old daughter who is the world's cutest vector of very communicable diseases. So if I hack my way through these remarks, you'll have to forgive me. As Michael mentioned, we at the Council on Foreign Relations recently concluded a task force on non-communicable diseases. It was actually our first task force devoted to a global health issue. For those of you that aren't familiar with the Council, it's a membership organization and a think tank, and our task forces are one of the signature initiatives that we do. They're typically led by former presidents or former secretaries of state, and this one was no different. It was chaired by Tom Donilon, who is the National Security Advisor for President Obama during his first term, and Mitch Daniels, former governor of Indiana, current president of Purdue University, and really even by the standards of our past groups was an all-star group. We had several former national security advisors, secretaries of HHS, surgeon generals, departments of agriculture, heads of all these US agencies. And how did we get them? These aren't people that had spoken out on NCDs before. How did we get them involved in this group? And the way we got them is we told them we were going to ask them 3 questions and that they could genuinely say no, that this was an honest inquiry. And the first question we asked them is, are non-communicable diseases, cardiovascular disease, cancer, diabetes, chronic respiratory illnesses, diseases that cannot be spread person to person, although they may be caused by an infectious agent that can't, are these diseases an emerging crisis in low and middle income countries? They've been around for a long time in high income settings. They've been, of course, prevalent in lower income settings for a long time. Why should we be concerned about them now? And to answer this question, we looked at the data of what this health challenge looks like in low and middle income countries. And what we found is that these diseases are increasing faster in much younger populations and with far worse outcomes than we see in higher income settings. What do I mean by that? In terms of faster, non-communicable diseases, the number of deaths caused by non-communicable diseases in low and middle income countries has increased 53% since 1990. That is nearly twice the rate of population growth in those countries. In Latin America, has the highest or the fastest increase in death and disability from non-communicable diseases outside of sub-Saharan Africa. And in Latin America, that is starting from a much larger base. Diseases like diabetes in Latin America have increased 82% since 1990. Breast cancer has increased 61% since 1990. Ischemic heart disease has also increased substantially in that region. But they're not just arising faster, they're arising younger. And in this report, we took a stricter standard on prematurity. We had a conversation on the last panel, what do you mean by elderly? Well, what do you mean by young? And in this case, we looked at the World Health Organization, when they look at this issue, looks at 70 and younger. We looked at 59 and younger. And what we found is in some regions, sub-Saharan Africa and South Asia, 80% or more of the burden from NCDs arises in populations 59 and younger. Latin America has more than half of its deaths in that population cohort, meaning 59 and younger, are from NCDs. Altogether, 8 million people died in 2013, 59 and younger from NCDs. But it's not just that they're increasing faster and younger, they're having worse outcomes. My good friend and former colleague Amanda referred to this in the last panel around breast cancer, but you really see that across the board. The case fatality rates when you're looking at cardiovascular disease, other cancers, diabetes in particular, are much higher in low and middle income country regions, and with people getting sick younger and dying earlier, it has dramatic economic effects. You don't have to take my word for it. The World Economic Forum released a report looking at what the projected economic toll of non-communicable diseases would be, and they project in low and middle income countries alone, NCDs will extract $21 trillion in economic costs by 2030. That is roughly equivalent to the entire economic output of all low and middle income countries in a single year. One of the things we thought coming into this task force is that, well, that's terrible, these diseases are a problem, but isn't this a sign of success? At least people aren't dying of malaria in the same numbers as what we have found. And when you look at the data, that's not entirely true. I think many people's expectations is that this would be driven by unhealthy habits and rising incomes, and is an unfortunate byproduct of something we should in a way celebrate. And what you found is that the rate of increase of non-communicable diseases is much faster than the rate of decline of communicable diseases. What do I mean by that? In low-income countries, non-communicable diseases are increasing 300% faster than the rate of decline from communicable diseases. In lower middle-income countries, are increasing 1/3 faster than the rate of communicable diseases. Many of the unhealthy habits that we think of as driving these epidemics, not as much as you might think in low and middle income countries. The rate of obesity in a low income country, the average low income country, is 5%. The rate of obesity in the average lower middle income country is 7%. In the United States, it's 35%. You see similar disparities around physical inactivity as well. What is driving it in these settings? Well, we've made great progress in reducing infant and child mortality, but those improvements, and that's driven an increase in longevity, but those improvements have not come with the same improvements in personal wealth and health systems that you saw when these transitions occurred in other countries. When OECD's countries reached a median life expectancy of 59, which happened way back in 1946, the GDP per capita in the average GDP per capita in those OECD countries was $4,600. When low-income countries reached a median life expectancy of 59, which just happened in 2012, the GDP per capita was $1,072, so significantly poorer. As was referenced in the last panel, health spending in healthcare has improved. Health spending by low and middle income countries tripled over the last 20 years, still really low. Well, I know this isn't focusing on sub-Saharan Africa, but to give one statistic on that, all 54 countries of sub-Saharan Africa spend as much on, the governments of those countries spend as much on health as the government of Poland. The governments of all low and middle income countries, representing 5.7 billion people, spend as much on healthcare as the governments of Canada, Germany, the United Kingdom, and France combined, representing about 300 million people. So that gives you a sense of those disparities, and that's particularly true, as we heard in the last panel, in Latin America. in many ways, Latin America is unique because they have the same issues around poverty and underdeveloped health systems, but actually much higher rates of these behavioral challenges we talked about. So, for instance, in Latin America, the rates of obesity are a lot higher than other low and middle income country regions. There are nearly 100 million people in Latin America that are either obese or overweight. So you have that combination of challenge. On the other hand, as was referenced in the last panel, there's historically more investment in public health in that region, and there's actually been a lot of progress on tobacco. So that is something good to be said about Latin America in terms of non-communicable diseases. So in terms of getting back to the original questions we looked at in this task force, we I think could soundly conclude this is an emerging crisis in low and middle income countries. The next question that we asked this group was, why should the United States care? There are a lot of crises in the world, particularly in health. Why should we care about non-communicable diseases? And I think many people's assumption about US and other donor investments in global health is that what we target are direct health threats to the United States. We heard a lot about Ebola earlier. And historically, that's actually where very little of our global health money goes. Most of our investments in global health go to maternal, newborn, and child health, HIV, malaria, TB. And in most of these areas, the prevalence of those diseases in Guyana has absolutely nothing to do with the prevalence of those diseases in the United States. We invest in them because we care about those countries and the populations they affect. So one of the things we did in this task force report is we looked at the 49 countries where the US spends $5 million or more, 4 of which are in Latin America and the Caribbean. $5 million or more annually in global health aid. And what we found is, again, looking at premature mortality, 59 and younger, the rates of premature mortality from NCDs in those same 49 countries is 3.5 times greater than it is for HIV. The rates of premature mortality from NCDs in those same 49 countries that we invest in is almost twice as great as the rate of HIV, TB, and malaria combined in those countries. That's not the way our investments work currently. The US government has no dedicated program or budget on NCDs as part of its global health work. If you look at those 4 countries in Latin America where the US invests $5 million or more, that's Guyana, the Dominican Republic, Haiti, Guatemala. We spent $30 million in global health aid in 2013 alone. We have not spent any sum on a dedicated program around NCDs in those countries since 2000. So just the last 13 years, perhaps something earlier, but that's as far back as our data took us. So the argument we would make is if we care about these countries and their populations, particularly their populations that are young, economically productive, raising families, we should care about NCDs. As Dr. Frieden mentioned, though, there's a lot you can do about this, and this gets to the last question, which is, we asked this group, if this is a crisis, and it's a crisis the US should care about, is there anything the United States and other donors could do to address it? And it is true, the long-term solution to NCDs in a low and middle income country, Latin America or otherwise, is the same as it is in a high income country. It's better preventative and chronic care. It's more sensible policies, particularly around tobacco, better urban design, better agricultural policies. That's a long-term project. That said, there are a lot of things we can do in the short term. Nobody waited to build a functioning health system before we addressed HIV. We did what was shovel-ready at the time and can make a tremendous difference on premature mortality. And there's a lot in that space on NCDs. We heard, again, Dr. Frieden mentioned this morning, if you wanted to invest in one area of international health where you could save the most lives, hypertension. There are very cheap interventions that are largely unavailable in low and middle income countries, and that's true in Latin America. Tobacco is another area where you can make a tremendous amount of difference. And before I turn it over to the other member of the panels, one thing we looked at the report is the role of the private sector. And our take is that role is at least threefold. Certainly there's the role for technology in these areas and lower cost chronic care. The critical element of this, though, is that that technology be frugal. It is not enough to import solutions that we have in high income settings to low and middle income settings and think of that as the solution. It has to be provided in a way that it's accessible to those populations given the infrastructure limitations. The second area is employers. Some of the greatest innovations you see are in workforce wellness programs in the private sector, and that can make a big difference in this area as well. And the last area, and this is where NCDs is different than other areas of global health. It is true that there are products and policies in the private sector that can contribute to the rise of NCDs. Certainly in the tobacco area, we need to do more on international tobacco control, on the issues around nutrition and better diets. I think there are a lot of great voluntary programs that can be done to make progress in that space. But I think, particularly in Latin America, you're seeing experimentation with other tax and less voluntary programs. And we'll see what those outcomes will be. Let me pause there.
Great. Thank you, Tom. Well, Tom, you've done a great job of teeing up the problem. So we're fortunate now to be able to hear from three private sector executives who are trying to address the problem. The first one, Dario Speranzini, is the President and Chief Executive Officer of Latin America for GE Healthcare. So Dario, share us what some of your experiences and activities are and challenges.
Okay, yeah. So firstly, I'd like to thank the World Affairs Council of Atlanta, the CARE USA, and the CSIS for hosting this very, very important event. I am honored to participate of this event with experts in order to try to find solutions to reduce the non-communicable disease. And yeah, this is very, very important. I'd like to start just highlighting some statistics. Sorry if I'm going to repeat, but it's very important to sustain my rationale later. So in Latin America, 3 out of 4 adult deaths are connected to non-communicable disease. The 4 most important ones you already mentioned, so it's diabetes, cardiovascular disease, chronic pulmonary disease, and finally cancer. So those 4 are representing today 65% of the total deaths in Latin America. It's a lot. It's a lot. And if you don't take any important and focused action on that, this number can grow up to 81% by 2030. Well, over than 200 million people are living with NCDs in Latin America. So this is not a local or regional problem. It's a global problem. And sometimes I ask to myself why governments and the society are spending much more attention and investment to infection disease than for the NCDs. Not because it's less important, more important, but taking consideration the size, I would say that we need to have a little bit more balanced investment and attention. I am leading Latin America, since 24 years ago in the healthcare systems. This has been I'm leading multinational companies in different subsegments, and this has been, to me, a very, very important opportunity. It's a journey, and I'm learning a lot. And I'd like to just use in my experience to select 4 points that can be important to reduce the NCDs, or help to reduce the NCDs. One specific point, a little bit more generalistic, is about the healthcare system. We have more than 40 important countries in Latin American Caribbean. And we see a very diverse healthcare system framework. Depends on the political regime, we have more or less government participation and activity. And I'm seeing in my career a lot of progress in terms of maturity for those healthcare processes. I see very, very diverse healthcare systems in the different countries, sometimes very difficult to compare. But all of them are very fragmented. There's no connection among private and public. So the second point that I'd like to highlight is lack of appropriate education background. So education is very important. It's true that Latin America is increasing its capacity in terms of education background, but still we have a lot of gaps, important gaps to fulfill. And one specific gap, I think, is the management performance. I mean, I don't think we have in Latin America today an adequate education in terms of management, and we are losing a lot of money by that. The third point is that lack of infrastructure investment. It's clear, it was already mentioned many times here. So we still need to invest. Some countries are investing more than others, but again, the ratio that we are investing in Latin America is not good enough, and a lot of bureaucracy. So those 4 points were points that I need to treat in terms of consequence. The consequence of not having the appropriate infrastructure investments. So it's in terms of early diagnosis is one of the ways to reduce the NCDs. If we don't have adequate infrastructure, we're not going to have the proper evolution that we are expecting to. So if you don't invest in infrastructure, NCDs will grow by 2030 for the ratio of 81% of the total deaths. The healthcare systems were built, under my point of view, around governments and their hospitals. It was a kind of chaotic construction. And I do think that the healthcare systems need to be built around the patient information. Everything else can be expanded from that. And this is the big mistake that we are doing. If you don't domain the patient information, it's going to be very difficult to connect the healthcare systems. And due to, the other point is due to the management performance challenge that we have today, we are seeing a lot of leakings in terms of investment. We are seeing a lot of waste, a lot of non-conformities in this process. And this can give us a false impression that we don't have money enough to do something. This is false. I think we can be much more productive if we can reduce the level of non-conformities by connecting the healthcare systems. So by saying that GE is committed to using our science, our technology to help doctors and governments to transform healthcare by early detecting the NCDs. Here I'm talking about a little bit about infrastructure, and be much more precise in targeting some priorities or some therapies. The second point is helping customers and governments to adjust or redesign healthcare systems, the healthcare dynamics, by having patient information as a backbone of everything. So public and private should be well connected, better connected. Here I'm talking about connection. It's about connection. The third point is contribute to increase education background. Just recently we started our operation. We made an agreement with one of the most important educational schools in Brazil. It's about 2,000 square meters, touching different kind of segments and subsegments modality in order to help physicians, nurses, technicians, engineers to exercise their profession much better. So, but I'm not only talking about technical and medical education background. Again, we need to invest in a managerial area as well. Finally, together with the government, and in order to have a sustainable environment, I think that industries should pursue to find different kind of partnerships with the government, identifying new business models. It's clear that we don't have money enough to invest in everything that we have in terms of gap. So innovation here in terms of business model is absolutely very important. So we need to find the way. Maybe PPPs can be one of the alternatives, but should be much better discussed. So this is my contribution so far.
Well, thank you, Dario. Next we have Fabio Landazabal, I practiced, but I missed it, who's the Senior Vice President in Latin America for GSK. So welcome.
And almost Brazilian.
Almost Brazilian.
I'm a true Latin American, so thank you very much, and thank you for having me here. It is really a pleasure and an honor to be here with you. I'm a physician as background, and I joined the industry a long time ago doing R&D, clinical trials, but then I moved to commercial. And I work for GlaxoSmithKline, a company that it is an R&D-based organization of prescription medicines, over-the-counter drugs, vaccines, and we try to work in many of the healthcare issues that we have been discussing today. So at this moment, we have quite advanced vaccines for Ebola. We are one of the companies that it is working really hard to bring a solution in Ebola. As well, we have solutions are working in dengue, malaria, and always very committed with access. So we already had stated that all the vaccine of malaria, we will sell it at cost, not profit. We will not make that vaccine for profit, and what we would like is to make sure that we increase access. But here today, I'm not going to talk about vaccines or preventable diseases. I'm going to talk about NCDs, non-communicable diseases. And as GSK being one of the leader organizations in respiratory diseases, we are putting a particular focus and effort behind COPD. COPD, it is at this moment the 5th leading cause of death worldwide. And it is estimated by 2020, it is going to become the 3rd leading cause of death. So we're very conscious about it, and we're very conscious about the issue. But surprisingly, not many people talk about COPD. Not many people know that COPD actually, despite that we know the etiology, that it is a very clear etiology and a very clear link with tobacco, with pollution, with exposure for a longer period of time to these risk factors, there is not a clear awareness in the population, in governments. There are not in Latin America, with some exceptions actually, programs to manage COPD. So there is a clear link between obesity and diabetes, and there are clear programs in Latin America to try to tackle that problem that we have. But in COPD, that is not the case. So today I would like to share with you the three main activities or initiatives that we are working in Latin America. The first one, it is data generation. If we don't know the problem and we don't know the statistics in Latin America, it is going to be very difficult to create effective programs in Latin America. So as we speak, we are supporting 5 independent trials, and actually everything that I will be talking today, it is in collaboration, because we believe that we alone, we are not going to be able to make the difference. So everything that we are doing, it is working with governments, it is working with medical societies, it is working with NGOs, it is working with patient associations. So all those trials that we're working are with medical associations and with governments. And at this moment, we found out that 89% of the patients suffering from COPD are underdiagnosed. So even though it is the 5th leading cause of death in Latin America, at this moment we have 89% of the people that it is suffering has not been diagnosed. And more staggering, when they're diagnosed, 68% they're wrongly diagnosed. So we start to work and try to say, okay, what we can do beyond that. So we had to support education in order to increase better diagnosis and better treatment. But clearly, that's as well a fantastic task that we're taking, and what we're trying to do is to try to do it in a different way. And we're trying to use technology, try to use internet in order to try to get to broader group of physicians and increase the capacity and the knowledge of the physicians in order to treat, diagnose, and manage this disease. So that has been a tremendous focus that we have been putting the last 2 years, creating educational programs and putting it offline and to make it available to everyone in Latin America. The third piece, it is to increase awareness and education in lay public. That's as well a huge task that we have been taking, but and creating and trying to make sure that the spirometry, which it is, and I know that many of you have had experience of doing spirometry, is not an easy test. It is to try to increase that access. So again, we have been working with patients associations, and I would like to share with you the example of Argentina. We have worked with the Pneumonology Association of Argentina and the Allergy Association of Argentina. And if you made the technicians, I would like to show you something which we have been going to the streets, and we have started to make spirometries in the streets. And in a period of 5 months, we did close to 13,000 spirometries. The consultation, because basically this was a program that we did trying to cover not only doing the spirometers in the streets, but as well doing campaigns in the TV and putting ads in the TV and making sure that those ads, they were replicated elsewhere, and doing spirometries over in television, in mass media. The consultation on the doctor's office increased by 30%. And the awareness of the disease increased from low 20s to almost 40%. So we doubled it in months. So we believe that it is possible to have a positive action in non-communicable diseases. And this is the picture of the people in the streets of Buenos Aires, and as well in some of the TVs, and doing the spirometry and making sure that people start to become aware. So we believe that it is possible to do a positive impact in non-communicable diseases. We believe that we can change the dynamic that at this moment we see, and at this moment the dynamic it is that we're going to continue suffering from COPD. But we have to do it first through partnerships. We cannot do this alone, and we need to work together. We need to look for new ways, new technologies. As I said, spirometry is a very difficult test, and as well it is not widely available everywhere. So we're working and trying to see if we can use mobile technology, and I know that all of you have one of these smart devices. So we are seeing that with the microphone of the mobile phone, you can try to see the flow of the air, how it is, with what velocity the patient is capable to blow through the microphone. And the beauty of this is that you as well, you could send the data from wherever you are, in whatever territory you are, and send it to a diagnosed center that it is going to be able to assess if the patient has COPD or not. Obviously, we're trying to validate all this data, but I believe that through creative thinking and working in partnership, it is going to be possible to impact non-communicable diseases. Thank you.
Thank you. Thank you, Fabio. I have a hard time even dialing the number right on my phone, no less checking my pulmonary function, but look forward to that. Our last speaker, Jacob Gale, is Vice President of the Medtronic Foundation. Jacob.
Thank you. And before I begin, there are three things I do want to talk about. One is about and they're all related, they're all about the fact that there are two sides to every coin, and in between there really is a porous boundary. One I want to talk about is the region, Latin America and the Caribbean. The other I want to talk about is the fact that there is a very thin border between communicable and non-communicable diseases. And then the third is the fact that from a philanthropy and from a corporate philanthropy perspective, it's possible to do both good and well in the same effort. But before I do, these two lights remind me of a story, a Caribbean story about a guy who went to the doctor because he was having double vision. He says, doctor, I get in double vision. And the doctor says, well, close one eye, boy, close one eye. So I think that, you know, as we look at some of the aspects of Latin America and the Caribbean, we see we're really talking about one area that is divided both by perhaps in some cases geography and perhaps in some ways culture. The Caribbean is, in fact, as broad as the region that we've all described, whether you're talking about the island states that people most traditionally think of, or whether you also talk about the countries like Belize and Suriname and Guyana and French Guiana, that we, in fact, actually the Caribbean Social and Economic Headquarters is based in South America, is that there's an overlap between what we traditionally think of as Latin America and the Caribbean. Cuba, Puerto Rico, Dominican Republic, very clearly considered part of Latin America. We own them in the Caribbean as well. And lest we forget the fact that 70% of all African-American community in New York City is either first or second generation from the Caribbean. The Caribbean can extend much larger and much farther, as does Latin America. And so when we have these boundaries, we recognize that these boundaries are very, very porous. We have to work together as one family and one community to try to conquer and try to deal with some of the things that confront us all. The second thing I wanted to just talk about is the area of non-communicable diseases. And while the UN definition of NCDs that some of us perhaps in this room were engaged in drafting and getting to resolution back in 2011, does really prescribe a specific group of 5 disease states that seem to be fairly clearly non-communicable. And some of them were mentioned earlier: heart disease, cancer, diabetes, stroke. COPD. And pulmonary, exactly. So, you know, when you take those 5, it's very, very clear that those are the non-communicable diseases of focus and of the statistics we talked about earlier. But when you look in some of the other disease issues, especially in Latin America and the Caribbean, things like rheumatic heart disease, to start from something very simple that many of us may have encountered sometime in our childhood, strep throat, that could be treated almost free, let alone maybe a couple pennies a day. But when there is no health infrastructure at all, or when there's such a poorly structured health infrastructure, strep throat moves to rheumatic fever, which eventually erodes the heart valves, that eventually causes rheumatic heart disease. And so the border between communicable and non-communicable can be very blurred at times. I think that's one of the reasons why when we really look at what the answer to the solution is, it's not so much specifically the verticality of our responses, but ultimately at the end of the day, it has to be about strengthening and building that healthcare infrastructure. And yes, it starts right from the beginning in public health, and it goes right to the end to tertiary care of the highest level if necessary. Let me talk a little bit about the company that actually gave me the ticket to fly here, Medtronic. It's the largest medical technology company in the world, and it has really been born of a mission over half a century that says that you can do good and you can do well at the same time. It has a mission to really bring about universal health care and to be able to use whatever resource it has, for-profit, nonprofit, whatever it might be, to make that happen. And so whether you're talking about some of the NCD programs that are focused in countries like India, South Africa, Brazil, here in the US, that really deal with some of the issues as I just described, or perhaps some of our work in neglected diseases in Tanzania, in Fiji, in Uganda around rheumatic heart disease, or even the fact that NCDs include acute episodes of heart failure, sudden cardiac arrest, diabetic acid, coma, that thing. As you realize that all of these are reflective not only of lifestyle that we talk about quite often, but in countries in Latin America and the Caribbean, it's reflective of the fact that societies have advanced very quickly, the revolution of social conditions that have not necessarily brought along with them the healthcare infrastructure and information that's necessary to be able to balance it. The fact that in many cases we're talking about economies of scale and scope that haven't enabled countries to be able to develop the more diagonal, as I call them, systems that are necessary to speak to all of these health concerns and issues. Personally, I think that if a country is able to call itself a sovereign country, it should be able to ensure that it provides certain basic human needs of each individual. And so therefore, I think that as we look toward what we do to respond to issues of the Caribbean or to Latin America, we have to take into account all of these things. It's one large community, different cultures, different expressions. The role of the private sector, both from its philanthropic side as well as its for-profit side, is really to be able to bring about those advancements in healthcare that are able to make a difference. Having worked in bilateral as well as multilateral development, having worked in NGO and private philanthropy, one of the things that I definitely have walked away with is that all of these entities are very important in advancing further the cause around NCDs and around the development of healthcare infrastructure. None of them alone are going to be able to bring them to scale or to ensure that they continue to build and grow as emerging threats continue to challenge our health status. One of the things that I think private sector can bring to the table is the business model for sustainability that's able to build systems that are able to bring about the resources themselves to continue them on so that they're able to bring about success in healthcare, to be able to scale them to the magnitude and the scope that are necessary for really making significant differences. I also think that as we talk about the private sector in the NCD conversation, we have to realize that there's more to private sector, and in due respect of all of us here, than those that are pharma, medical device, or other obvious partners in the healthcare discussion. What about for-profit media? What about engaging other businesses and other enterprises that have a vested interest in our behaviors, in our lifestyles, in our outcomes? It's really hard in the case of Latin America or the Caribbean to try to change tobacco use or obesity or to encourage proper nutrition when all you have is a government information service that's being able to advertise on television or radio, while at the very, very same time, for-profit media is able to show that if you're glamorous, if you're young, if you're really on point, these are the kinds of things that you want to do, or to have, or to eat, or to smoke, or to drink. And so I think that we all have to be held accountable for the fact that we each have a responsibility to the public and to the populations that we serve, and we all have a talent, an expertise, and ability to make a difference. At the end of the day, when we go home or we go to the supermarket, we go to our places of worship, whether we're from private sector, public sector, civil society, we're all living in a society with non-communicable diseases, some of us, in fact, living it ourselves. And so for that reason alone, just as members of that global society, we each have a responsibility, and we really all have an opportunity to bring a multi-sectoral partnership together around NCDs in the Caribbean and also in Latin America.
Great. Thank you. Thank you, Jacob. That was great. I was trying to think about where to go with starting a dialogue here, and folks get ready to ask questions from the audience. And the thought that comes to my mind first is that there seems to be a unintended competition between infectious diseases and non-communicable diseases, at least in terms of how they're talked about and competing for resources and media attention and other things, when in fact we talk insufficiently about health, and that's really what we're about, whatever the cause is, and that there's probably more commonality than differences along that continuum in terms of solutions and around capacity and surveillance and data and clinicians, but it's unfortunately bifurcated somewhat. And I know the NCD community feels inferior because of the resources and the attention and also the burden being so high. And then when there's an effect, like an Ebola outbreak, which is, grabs everyone's attention, lots of resources, there's a little bit of jealousy about that. And so I guess the first question just to throw out is, how do we overcome that? How do we not look at our silos as much as we do, whether it's an NIH silo or a public health or a disease silo, but think more broadly about how do we improve public health in general. So anyone jump in if they want to.
Sure. The one thing I would say is I do think at this point, in terms of the division of resources, it hasn't been much of a competition in that the resources are, at least from an aid perspective, dramatically skewed towards communicable diseases. The United States, the United States spends $10 million out of its global health budget of $8.4 billion on NCDs. If you look at that per DALY, that's roughly $49 per DALY life lost to NCDs in those 49 countries, around $5 per DALY. For life lost to malaria, $1.80 per DALY for life lost to TB, and 2 cents for NCDs. So they're dramatically different currently. I do think progress can be made, though. I think from an NCD perspective, one danger, and I take Jacob's point quite well, that NCDs as a category are enormously broad. Really what it is it's the diseases and conditions that become more prevalent when a population transitions from the plagues and parasites that kill children and infants to the diseases of people with longer lives. They're not all non-communicable, they're not all chronic, it's a broad category. So, but I think progress can be made by focusing on those diseases that are arising in young populations, disproportionately affect the poor, and that we've made enormous progress on reducing premature mortality and morbidity in other settings. Or it's effectively the same framing that we view a lot of global health problems, which is around inequity. And I think we can make an enormous amount of progress by NCDs by focusing on those areas. I think there are great opportunities for integration. A lot of the international initiatives that have been set up around HIV, which is a chronic disease, are the largest chronic care providers in some of the countries they operate. I think there are real, you've seen some integration go on in the areas of particularly cervical cancer and some trials on diabetes. Those should be expanded. But I do think at the end of the day, we do need to see an increase in donor resources. The long-term solution for NCDs are with the national and local governments. But in all other areas of global health, the role that international initiatives and aid has played has been catalytic. It increases international attention, it shows what's feasible, and improves accountability. And I think we need to see that in NCDs.
Any other comments?
Well, quickly, I came back to the visibility of the information. I think it is not a matter of comparing one area to the other, but it's a matter of having much more visibility, and which is clear that here in the US we have much more access to the correct and precise information, which is not the case in Latin America. So one, visibility of the information. And second is about how to treat that from now on. So, I mean, how to evolve from the moment that we have this infrastructure, from the moment that you have this visibility. Again, my point is we need to have everything based on the patient information. If you can build this, then the rest is going to be easier. Yeah.
Well, I think that from my experience, and I had the opportunity to not only to work in Latin America, I had to work in the past in Asia Pacific and in Russia. I think that Latin America is quite ahead in the communicable diseases and in the prevention of diseases. And I think that what PAHO has done on strengthening the vaccination calendars had put Latin America in another league. So I think that we have done tremendous progress in that area. When we look communicable diseases, non-communicable diseases, I think that the challenge it is bigger because here we are talking changing lifestyle and educating people. I think that it is much easier to vaccinate someone and to receive a vaccine, an effective, safe vaccine, and to prevent the disease, and then you move on, that actually educating public and asking them to change their lifestyles. So I think that first we need to tackle this from multi-factor areas or multiple areas, but we need to take in consideration, yes, government, societies, etc., but at the end, it is the individual. And if we don't raise education in Latin America, and we don't increase education, it is going to be very difficult to really tackle this problem.
I think that there are two approaches. One, retroactively, it's possible to build upon the vertical systems that have been built out for things like maternal and child health, emergency childbirth, HIV, immunization, and be able to see how some of the systems that were built for those are able to now be used for NCDs. And we're seeing that in certain parts of rural Central Africa where there have been systems for emergency transport for delivery. Well, we're able to use the same thing for acute care kinds of issues, or on and on. The Ebola response in West Africa showed that the countries that had the HIV systems were able to then be used for other infectious diseases. We can do that across the NCD communicable disease as well. But I think proactively, it's really thinking about a whole new paradigm of how we respond to diseases, so that we first and foremost think about the common layer that needs to be built, whether it is disease of today or disease of tomorrow, and then add to that the specificities of the urgency of the day.
And I'd just like to follow up on Fabio's comment about the difficulty with NCDs because they involve lifestyle and behavior. And one of the things that has changed in the States particularly, and was led by European efforts, but having a focus on policies and systems and environments that make it easier for people to behave in a healthy way. All of this idea of nudging and tax policy and clean indoor air laws, where the burden isn't on the individual, him or herself, to change without a supportive environment to live within. And I think that's where a lot of the effort's going, to help the person make the healthy choice. And I'm not sure it's happen as spontaneously or as quickly as it needs to happen, or it's happening as globally, but that's, I think, a direction that's a bit of a change.
I just wanted to add one thing. I think that's well taken on the behavior thing, but I did want to point out that this is not just a challenge with non-communicable diseases. The primary modes of transmission for HIV, behavioral, sex, and IV drug use. Many of the areas where we made progress on maternal, newborn, and child health, behavioral. We know how to do this. I think it's a question of investing the resources to do this at scale on some of these non-communicable disease problems as well.
Right. Mm-hmm. And we can't see that well if there's anyone at the microphone, but if there is, there's not yet. Okay.
Can I just add something on to that as well? And I was going to say is that you're absolutely correct in terms of the behavioral aspects of NCDs, but lest we forget the fact that I think especially in lower income communities, oftentimes it's environmental and other issues. You know, it may be, think about COPD, it may be from non-regulated emissions from, pollution. It may be cooking stoves inside of the home. It may be other kinds of things that, yes, are semi-behavioral, but are also really out of the control of the individual and are really needed to be larger public policy issues as well.
Thank you. I think we have a question on our right.
Yes. Hello, I'm Sophia. I'm a recent graduate from the School of Public Health here at Georgia State, and I'm a nurse by training from Brazil. And I want to hear the panel perspective regarding the politics and the policy scenario in those countries, because as probably you know, some countries are facing challenges in terms of even the democracy, such as Brazil, Argentina, and Venezuela. And I would like to understand if regarding the partnerships.
Sorry, I consider myself young, but I'm not hearing. I think that there is an echo with
there's an echo.
Can't hear.
With the. I don't know how we can. I don't know you, but it was difficult to follow the question.
It's just I would like to understand. Is better now? No, can I understand now?
No, well, go ahead. Maybe if you speak slower, I can hear you better.
I would like just to understand if you think the process of democracy is some crisis that might be happening in those countries such as Brazil, Venezuela, and Argentina. You think is influencing the establishment of partnerships or investments to bring this to those countries? If you think if those countries are in crisis in terms of the policy, if you think this is a challenging to bring investments and establish partnerships in those countries?
Yeah. Well, I could share with you, let me see if I understood correctly the question. You were talking about that basically on the political situation of those countries, that it is possible, if it is possible to do partnerships with governments in those countries? If there is a challenge? I think that overall, transparency, it is a challenge in Latin America. So we know that when you see in the transparency list, many of the countries of Latin America are way below the 50, which is considered at this moment like the threshold of transparency level. So yes, the lower that you go, the more difficult it is. But it is possible to do it. I think that we have done it in Brazil. We have a long-lasting partnership with Fiocruz. As well, we have done it with Butantan, and we are now with FUNES, which we have done technology transfers, and where we have made our vaccines available in Brazil through those technology transfers. And now we are moving into co-developing some solutions. So our dengue vaccine, it is co-developed, or we are working together in that challenge with Fiocruz. So yes, it is possible to generate transparent partnerships with governments like we have done in Brazil. Obviously, to replicate such partnerships or collaborations across other countries, it starts to become more difficult. And I think that one of the topics that we were discussing last night, it is how the lack of transparency of the corruption affects the healthcare outcomes in Latin America. Because we know that many of the resources of Latin America, they go into actual investment into healthcare, and that somehow we need to try to improve the transparency and the decision-making in Latin America, and that many of the resources that at this moment are being diverted are well invested behind the priorities and behind the needs of Latin America. And we know that large portions of our GDPs, they're going out of the system. So I think that is an overall issue that we need to tackle. I think that at this moment it is possible to generate those partnerships, but we have to be careful how to do it and with who you create those partnerships. And that is why it is very, very important to work with organizations like PAHO that brings a lot of transparency that enable you to work through the governments, but definitely it is a challenge that we need to learn how to operate in Latin America.
Yeah, I mean, just complementing, I have very good experiences recently in establishing partnerships with some countries in Latin America. Brazil specifically, in some states, it's easier than others. And Chile we are also learning how to do these partnerships in Chile, in Peru, now in Colombia. So things are moving in a proper way, slowly but moving. In Brazil also, we had opportunity to finalize an agreement with Hospital das Clínicas, Universidade de São Paulo University, investing together $30 million in the coming 5 years in R&D, which is something very, very new that we couldn't imagine years ago. So I think the industry is also starting to understand and learn about how to approach the governments. I think it's possible, and we need to move on. Mm-hmm. So Brazil is one good opportunity, and we already see some outcomes here. But again, we also can do more or less the same in Peru and Colombia and Chile. PPPs are appearing everywhere right now, so it's a good moment to push. Mm-hmm. Yeah.
I think we have time for one more question.
Thank you. Dr. Spence Lewis, CDDF, Community Directed Development Foundation. The organization is in Ghana, West Africa, and we work with community health. One of the aspects that I'd like to draw to the attention to this meeting is that there does not appear to be a clear definition of what the Caribbean region constitutes. Because there are many islands in the Caribbean, I'm not speaking about political or social or cultural, there are many islands in the Caribbean. For example, Guyana, some people consider Guyana part of the Caribbean, other people don't. So I think we have to be very clear about if we're going to treat health and public health, we need to be very clear about the definition for surveillance and for methodology and for other reasons. We have Grenada, we have St. Vincent, we have St. Lucia, we have Martinique, and all these islands have their particular health problems. And also, this comment is made within the context of travel medicine. And further, you have migrations from other regions, for example, South America, and from inter-islands that come into these islands, in chikungunya, dengue fever, and other conditions. And particularly in the urban area, you have leptospirosis, which is also a problem in South America.
Mm-hmm. Just the point that, I mean, and
the lack of clear definition of what the Caribbean constitutes in terms of public health and medical care. And I've given just a brief background to show why I put that statement about a definition forward.
Thank you. I was just going to say that I think one of the added challenges is that the Caribbean region really is politically so diverse. So you've got, you've got independent sovereign countries, you've got parts of the Republic of France, you've got dependencies of the United States, you've got all those on and on. The ability to be able to have a regional approach is a challenging kind of an issue. But I think when you look at it nation by nation, then that's a different specific kind of.
But I said in my content that we need to put the politics aside. If we're going to treat people, we have to look at a regional and
Right.
the aspects that I know politics, that's history.
Right.
Since the 17th century and the 16th century. But I'm speaking about the modern problems that the region of the Caribbean constitute.
Exactly.
And we have not given a definition on what the Caribbean is.
Exactly. I agree with you.
Thank you. Well, please join me in thanking our chronic disease panel. I believe everyone will be here for follow-up questions at lunch, and I'm looking for Cedric or someone else to give instructions for next steps.